The first thing we have up, or we had up, is the department will be given, this is a tease for next meeting. Next meeting is June 10th. And the department has already onboarded their new database and the new web design and streamlined web search. So everybody should have, you all who have gotten the invite should have gotten the letter that we got, or the email that we got from Martha Harbin. She'll be giving an update. It's somewhere.
I got it.
It was up here when everybody joined us.
I know. There we go.
There we go. All right. Anyway, so it's mobile friendly, and the clear licensing details. I believe that has anybody looked at the new website yet? I believe that maybe I don't know, Jeff Lynn, did you look at it? Susan Ramsey, have you tried it, and is it a better mousetrap? Are we able to access?
I wasn't even aware that they had updated their website. They updated their website previously, and treatment centers were searchable, but according to this is brand new. So
Yeah,
I haven't.
we got a demonstration of what they were going toward. They have new the new database is using new software, and
Right.
you're supposed to be able to access under one banner instead of having to look
Yeah,
at
different drop downs before. It's complicated. Yeah.
Yeah, and so please, anybody and everybody, take a look, if you would, at the database and see if it is more user friendly, and whether it has, again, more data that's accessible to, especially all the different offerings of each provider, and applications, reports, administrative actions. They should all be very easily accessed now. There is no qualitative, and I don't know that there ever would be or will be, like ACA has a star system. I don't know that that's ever going to happen with the department, but they'll be explaining that next time. So looking forward to it. A little tease for June 10th. The numbers are really something else. We are continuing on our pathway to, our goal is 0 opioid overdoses in Palm Beach County and the state of Florida. Well, that may not ever happen, but we are on our way to, we haven't seen numbers like these since before 2015, before the fentanyl and the issues that we had with fraud and abuse that was going on 10, 8, 7, 6 years ago. So at first, I'm going to go with the 24. Where are we? Are we here? Okay. 24, 25 numbers. In 24, there were 244 opioid overdose deaths in Palm Beach County. 222, 91% were fentanyl related. In 2025, we won't get these numbers from the state until November, December. But in Palm Beach County, thanks to we have a great relationship with the medical examiner, and we've gone down from 343 total drug overdoses to 262, total opioid overdose deaths 166. You have to go back well over 10 years, maybe even to 2010, 11 before to see numbers that are as low as that. Total fentanyl 148. The decline of opioid overdose deaths is 32%. 24 to 25, it was over 40% from 23 to 24. So we are really trending well. I will say that you also got in your attachments the medical examiner's annual report for 2025, and there are discrepancies in the numbers. While the total numbers in the 25 report, let's see, it says 232, but in their annual report, a manner of death is not how they do their annual report. They include drugs present. So in other words, if you have a homicide where it's not an overdose, but you have fentanyl present, that would be present in a report, which is all cases where drugs are present, but not in the total opioid overdose deaths that we get reported, which would be lower in numbers. So if you see a discrepancy there, that's the reason. If the numbers are higher in the annual report, and likewise in the annual medical examiner report, that may be a factor because we're usually as many as 10 or 15 off of the state numbers. But these are the numbers we have right now. Xylozine's gone down 71%. Fluorofentanyl is down 77%, 60 to 14. Carfentanyl's down to 2, ketamine's down to 1, or up 1 actually, which is not statistically significant. Now here's a snapshot, and this is a small sample size for 2026. And we have the first 3 months. You see in the first 3 months of 25, which we're comparing this to, there were 41 opioid overdose deaths. So far, we've got 19, which if you were to extrapolate out, this would be incredible. We'd be below 100, but there are 10 pending cases, and this is a snapshot over 3 months. So while, it looks, like an incredible reduction, I will caution everybody, keep in mind that they haven't looked at all the toxicology reports for the suspected overdoses, and we only have a 3-month sample. So, cautiously optimistic, good news. Sent out an article to everybody from NPR on a couple of drugs that, in fact, we just contacted the medical examiner's office, and they're looking into this because they are not looking for these drugs, cyclorphine and metatomidine. Metatomidine. I hope I'm pronouncing them right. But while even nationally, this is a national look at data, nationally, there's been a huge reduction in 2 years. The rolling numbers from the CDC has us down from 113,000 drug deaths in August of 2023. These are, this is October. October 25, the 12-month rolling number was 71,542. That's still huge. But again, this is a national trend of people, especially young people, dying from drug overdoses. Any questions about these numbers? Any thoughts? Any comments? Again, a lot of different things go into this, none the least of which is there's less fentanyl in the marketplace. The silos have come together so that we have more MAT available in recovery residences, as well as in treatment facilities, as well as, most importantly, through the healthcare district and other providers, outpatient MAT, which is saving lives. And I'm sure that Dr. Phillips will talk about that. Now, lastly, I want to talk about the transports, which is part of it. We're not seeing the number of transports, and there's been a 72% reduction since 2017. But when you look at those numbers, even from last year, 39% off of last year, from 12/31 in 24 to 7/45 in 25. These are end of year numbers. So all this is very encouraging, and I'm going to move on to R. Now, I don't know that I called for in the member role.
Angie.
Is Angie? Angie's here, but she
Yes, I
will be
am.
a panel member as representing for her. Angie, you want to give us the update on the numbers for the 4 certified beds?
Sure, no problem. Thank you, Al. Thanks. It's nice seeing you. Just want to do a shout out for Josh, who had a little baby girl last week. So I am, just stepping in for him while he's taking care of that little girl. So are we able to pull it up or, I mean, I have it printed.
Yeah, we'll get it up. We'll pull it up. I do want to
Okay.
mention that we have Commissioner Weiss who's tuned in. We also have Kelly Lee from the department. And Kelly, I've mentioned earlier, I know everybody's hair's on fire because you have all these new databases and new production coming online last week and this week. So I don't know, while we're waiting, oh, it's come up now, but you may want to mention how everything's going over DCF.
It's going really well. There are little hiccups, but basically it's just an adjustment to what we had to adjust to before, but it seems to be populating quite well. And the IT team in Tallahassee is really working diligently to get everything going and addressing any kind of snafu that we may encounter. So thank you. Thank you for bringing that up. It is pretty good. I've had responses from some of the providers that have said that it seems a better approach on their end. So naturally, that's a good thing.
Okay, great. And we're looking forward to the presentation and demonstration in June.
Great.
Okay,
Thank
Angie, go ahead.
Okay, great. Thank you. So statewide, our programs, certified programs were at 276. And that's as of last Tuesday. Number of units is 1,917 and number of beds is 9,556. As of today, that number has gone up because we just certified in the last week 3 more providers. So our beds have increased by 183. So we're at 9739, which is great news that we were able to certify that many more beds in the last week. Kudos to our certification team and the rest of the team for that. The levels 1, 2, and 3, total units 973, and the beds in those levels is 5483. Level 4 units is 944, and the total beds on the level 4 is 4073. There is the breakdown for Broward County at 27.8% in units and 25.2% of beds of the total of the statewide. And in Palm Beach County, the number of units is 40.2%. And as far as beds, we're at 36.7% of the total statewide beds. In Palm Beach County, we have 101 certified providers of that 276 providers that we mentioned. That would be 770 units at which accounts for 3,509 beds. And you can see the breakdown there. Out of that, we have none in level 1, 58 programs in level 2, 3 programs in level 3, and 49 programs in level 4. And in the next page, you'll see the breakdown per counties throughout the whole state of Florida. So I'm, of course, not going to read all of that, which I know Josh doesn't either, but we can probably just scroll a little slowly through that so y'all can look at the numbers and let me know if you have any questions, and I can hopefully answer them for you as gracefully as Josh does at every meeting.
Angie, I would ask you, because I normally ask this question, are there any areas in the state where you're seeing growth between the last meeting, say a couple of months ago, and now? Only because, as you look at these numbers, 67% of the units are in either Broward or Palm Beach County. And so it's important to note, and I know there's a lot of outreach to other parts of the state where you see there being inroads.
So we have, I believe, in the last month received a total of about 27 new applications that we are working on, and it's pretty diversified across the counties. We have a new contract in Hillsborough County where we've received 4 applications coming out of there. The last 3 providers that I just discussed with you, one of them is from Tampa, Jacksonville, one is from Flagler County, and one is from Miami-Dade. So it's pretty spread out statewide. Our regional coordinators reach out to multiple non-certified providers and stay in touch with them, pretty much trying to, reach out to those non-certified to get them applications in. So it's pretty, spread out.
Okay. Great, thank you. Anything else, Angie, from your perspective before I open it up for any questions or comments?
Not on my end, no, sir.
Any questions or comments? Okay, hearing none, let's move on. Thank you,
I
Angie.
have a quick question.
Oh, I'm sorry.
Yeah.
Dr. Phillips.
Yeah, so when these beds are available, how does it sort of interact with the opioid settlement dollars going towards housing, especially in Palm Beach County? Is it
Before you
just
answer that, Angie, I'm going to kind of preempt it by saying that Dr. Green.
okay?
There's
Excellent.
Yeah, we're gonna have a presentation about a county initiative. This is for Palm Beach County, obviously, not for the state.
Mhm.
But as you know, the state oftentimes has a template for the rest. I mean, the county has a template that's picked up by the rest of the state, like the arrangement that you had with JFK in terms of a receiving facility. We were the first, and the state adopted it. So I'm really anxious to hear what the county's doing. And so unless you had a different question for Angie, I'd rather wait until.
That's totally fine, because I think, just to preempt that, you're talking about breaking down silos. If you go, there's a lot of people living unhoused who have to be diagnosed with a substance use problem. They're not necessarily presenting to places that do that. They have to be diagnosed and then identified as someone for those dollars and then find that bed. So I don't know if there will be some coordination of all of that, whether it's the county individual doing the homeless outreach or the provider or whatever. But if there was some indication in some of these systems, like how you could kind of marry all 3 of those, because as a provider myself, I want to diagnose so I can say to the team, hey, this person could use those dollars and get into these beds that I'm seeing. So I just wanted to throw that out there. Thank you.
Okay, thank you, Dr. Phillips. Angie, do you have any response other than the program?
No, actually, my response was going to be the recovery housing initiative that Palm Beach County is rolling out, and I saw it on the presentation as well. So I was going to defer to the presentation as well.
Oh, thank you.
Yeah.
Okay, great. I see Michael McKeough from Oxford House. You have your hand up.
Yes, so Angie, occasionally I'll get phone calls from people that prospectively want to rent their home out to Oxford House, but they really want to do their own kind of thing. And I've always given them the FAR information to go ahead and get certified. I'm just wondering if that process to start becoming certified is still the same. What information should I give those individuals?
Definitely to go on our faronline.org website and put in their application information. It's very simple application information. And then our certification team will reach out to them with the process. We are processing applications very quickly, depending, of course, on their response time on their end. We've simplified the process to give quick response time. We're certifying as quickly as 45 to 60 days, if all goes well. And that's pretty much it. And I can also give you our general phone number so that they can contact us directly to discuss that process. And it's 561-299-0405. And I can put that in the chat.
Awesome. Thank you.
Okay.
Thank you. And we're going to move on. Now that you've got your mic open,
Sure.
Michael, go ahead and give us the Oxford house numbers and how are you doing?
Yeah. I mean, things are going really well. It's been like, what, 6 months, 5 months since we last met. Continuing to grow. We're at 299 houses across the state, 2,600 beds. Men's houses at 181, women's houses at 50, women with children's houses at 60, and then we have 8 men and children's houses now. I just kept this pretty brief. It's just been a lot we've done in the past few months, and we just held our 5th annual state convention. Went really well. I think one of our best conventions yet. Had some outside people come in. We had Anna Moore from the Florida Certification Board come in, talk about becoming a peer specialist. We have a lot of interest in our membership of people becoming peer specialists. And so that was really cool. But yeah, I mean, things have been going really well. We do have a documentary premiere coming up throughout the state. So some of you have probably seen it. We had a 60 minutes video done back in like 1991, which is awesome and great, but it's a bit outdated. And so we've got together like a phenomenal documentary crew, and they put together about a 50-minute documentary on Oxford House. And so I do want to formally invite anybody to attend one of our premieres. The one in West Palm is going to be at the Rinker Playhouse from 7 to 9 p.m. on June 11th. And I will send out more information to everybody. And if you want to come, just let me know. We'd love to have you. I'd love to have some input from the task force. And yeah, that's all I got.
Thank you, Michael. Appreciate that. Hey, just so that if anybody's just joining us, because we do have people coming on, as we go along to observe the meetings from the public, remind us again when Oxford House first entered into the contract with the state of Florida to have the first Oxford House open up. When was that?
February of 2019. We opened the first house in March of 2019.
So in 7 years, you've grown to 299 houses.
Yeah, we'll be at 300 this week. Yep.
Remarkable.
Yes, it's
awesome. There's a hand floating around there. What did Paul Stevens? You're not. I know you're not.
I think he's just congratulating. Yes, Paul is our nationwide legislation individual, and so he deals with a lot of the states and legislation and stuff like that.
Paul, were you instrumental in getting the state to recognize that Oxford House was part of the solution back in 2019?
I was not. This is kind of a new role for me. I was actually doing what Michael does in Florida, in Virginia, DC, and Maryland for about 15 years prior to that. But just last year, I took on the national role for state policy and public affairs.
Okay. Since you were more on the national level previously, and this is kind of like self-promoting for the state of Florida in terms of certified and Oxford housing. Is there any state in the United States that, and I'm just going to spitball the total, 12,500, 12,300 certified or Oxford House beds? Is anybody coming close to us in what we've done here in the last 10 years?
As far as the speed of the expansion, absolutely not. In the entire 50-year history of Oxford House, there's never been a state that's grown as effectively and fast as Florida has since we got that contract. I mean, there's a couple states that have more houses still, but that's because they've contracted with the state for the last 30 years. So no, what's happened in Florida is really great and remarkable.
Yeah, and Paul, I was adding on the numbers from FAR
Oh,
because
oh, well then,
uh,
yeah, you probably have I don't know the answer to that, but I
okay,
suspect you may have every state beat when you put both of them together.
yeah, I can't. Last numbers I heard was there was nobody over a couple of thousand, few thousand certified through a NAR affiliate.
Yeah, I
I
think
could
that,
be wrong on that. Maybe somebody can chime in. I don't know if Angie's aware, but uh, I just say that because I'm pretty proud of what we, and that's a large we, everybody on this panel and everybody throughout the state, everybody in the legislature, the legislators who have worked so hard, and employees at FAR, past and present, that have worked so diligently and hard to get us to this point. We're still growing, and it's remarkable. So thank you, Paul. I appreciate it.
thank
Nice
you.
meeting you.
Sure, you too.
Okay, seeing no, we have another hand.
Yeah,
Um,
it's just me. It's Sarah with the Department of Children and Families. I just wanted to say I attended the Oxford House convention last weekend and just want to give a shout out to them. There was a magnificent presentation that was done on the acceptance of medication assisted treatment in the houses and how to support individuals through that process. And I'm not sure, Michael, how many people were in attendance? Maybe like 200
It was about
participants.
350. Yep.
Yeah, it was a large number of individuals who were receiving that support from Oxford Houses, and to hear the stories of just the challenges that they were going through and the way that they were supported, it was an incredible opportunity. But that medication assisted treatment presentation was the best I have seen yet. So I just wanted to shout out real quick.
Sarah,
Thank you, Sarah.
Sarah, Michael, was that presentation on Matt? Who presented? Was it somebody from Oxford House?
Yep. Yeah, so several of our Oxford House staff, but I think specifically Jeff Siegel really headed up that part, and yeah, he did great.
Do you think you
Yeah.
may be able to get Jeff to present to the task force in
Yeah,
June?
absolutely. Yeah.
Awesome. We'll talk offline. Thank you.
Okay. Yeah, thank you.
Perfect. Any other comments on Oxford House numbers and Oxford House? I think the NAR national program is what, June 10th? Does anybody know? Angie, do you know? I thought the national conference for NAR was
I
coming.
End of
The NAR,
September.
It's in
the NAR
September.
National, the NAR National Summit is September 28th to 30th at the
Okay.
Fort Lauderdale Marriott Harbor, which FAR is hosting. And if you want any information, I had just put my email in the chat. I'll be more than happy to email you the information. We're looking for a call for proposals for any speakers who want to present. You still have a week to submit that. You don't have to submit an entire presentation, but just a summary of the presentation. We're also looking for sponsors, and you can tell that I'm on that committee right now. And registration will open the first week in May for early registration to get in on that, because it's going to be a hot number. It's going quickly. We're expecting over 500 attendees.
Awesome. Well, thank you for the information and thank you for putting it on the chat line. Any other comments, questions? Let's move into the last update is actually an agenda item as well from the Palm Beach County Healthcare District. And I do want to make a note that coming up with the Palm Beach County Recovery Housing Network through the county, the presenter on that is going to be Dr. Joanna Reed-Enoys. It's not going to be Dr. Green, so I wanted to correct the record on that, but that'll be coming up right after Palm Beach County Healthcare District. And it's remarkable what the healthcare district has been able to achieve, along with, again, separate silos coming together into a working partnership in Palm Beach County. And I wanted to, without further ado, I think Dr. Phillips, are you starting this off, or is Dr. Andrick starting this off?
It's me, and Dr. Andrick's here too.
Great.
Okay, thank you so much, Al. And
Did you want us to,
nope, I
okay,
got
you're
it.
gonna do it? Okay.
Okay, can you see my screen?
Yep.
It's really great to be here. Welcome back, Al. I love this group. There's a lot of great energy in this team. And I have a lot of partners on this call that I really enjoy and appreciate working with over our missions, our shared missions. So thank you to all the housing groups, the social groups. If it wasn't for you guys, our patients wouldn't get better too. So we need all of that. Thank you. And all the regulatory. So I'm going to give an update in current state today, and then I'm going to talk a little bit about how this plays into our bigger strategy to continue to improve our system of care overall for both behavioral health and substance use disorders that often are one and the same for many of our patients, right? So currently, what's happening? So I just want to update. We have on the behavioral health standpoint, we have 7 psychiatric providers, 3 MDs and DOs, and 4 mid-level providers to see adults and children. And we also have a lot of mental health professionals or therapists, as they're also called. And we really are starting to increase our footprint and believe in peer support as a service line, a very important service line for our patients that's very distinct and separate from clinical service lines, as well as care coordination. And I think that's one of the biggest areas we really want to grow in our workforce too, as well as care coordination and case management, which I'll talk about later. But as you can see, these are our locations throughout the county. We provide our major behavioral health hubs for psychiatric and mental health care. Our Mangonia Park, as many of you know, is open 7 to 7, 7 days a week for outpatient care. But we do a lot of innovative things at that clinic to stretch our outpatient care, such as have a Pyxis machine. We do, someone's in withdrawal, we can treat them there if it's not severe. We start medications there all the time, and we also have therapeutic services groups, care coordination and whatnot, and police drop-offs here. Our Atlanta Center, as you can see in the middle of the county, is actually our pediatric mental health hub, and it's integrated in our pediatric primary care clinics and dental. If you haven't been there, it's a beautiful flagship site. And down south, we have Delray Beach Health Center. We have a psychiatrist there, we have mental health, we have primary care, dental, so we're integrated around. I actually go out to Belglade once a month to provide services, and we provide teleservices as well in between. And we have a therapist out there. So we have psychiatric care once a week at West Boca. So we provide lots of care everywhere in terms of mental health. And when I say mental health, it includes substance use treatment. None of our providers can do one or the other. Everybody treats both, because if we can't, we're not treating the whole patient. So mental health includes substance use disorders in this case. Here's our QR code and how people can schedule appointments. So if you have anybody who you think needs help, this is the easy way to get going. I do want to give you guys a caveat. If anybody has a bad experience with the phone, we just changed our call center to a new group, and they're doing a great job. But it's a time of transition. So if you're having any issues, please call me directly or reach out to one of the people you know at the district, that we can help you get the patient in front of you serviced, as well as possibly learn something so we can give that feedback to our new operational call center and fix the problem that anyone's experiencing. But I hope that doesn't happen. Another update is our evidence base. So we tracked 5 years of, I've showed this in the past, of brief addiction monitor data, which is a functional recovery scale. We have over 7,000 surveys, and we got published actually in February of 2026. Dr. Andrick and I and some partners from FAU did a big data review, and we showed clinical outcomes, 5 years worth of clinical outcomes in this paper. And we were published in Addiction and Clinical Sciences. You can look on Google Scholar, but this is Palm Beach data. And it's really important because when I was trying to figure out how are we going to address this problem in our system, I looked to the literature, and most of the outcomes from clinical side were 30 days and maybe 3 months. This is 5 years in a real world setting of a validated tool, 5,000 surveys that we published. So we're really proud to share this information with the rest of the academic and recovery community to inspire others possibly to use this, and also to show that we We're always trying to improve and we're always trying to look at things from a data-driven standpoint. So we're proud to share this. This is our data. I would say you guys too. Everybody's patients who've been referred have been participating in this. And we'd love for you to read it.
If I can just interject, Courtney, like
Yep.
this group really was very instrumental in asking always the question, like how we are measuring the success of substance use disorder treatment programs, right? This is a functional measure of recovery, like, right? This is the standard tool that everybody should be using. I spent a lot of time on this meeting arguing with John Hulick in the past, like because he was really strong advocate for the tool, but we didn't use the same tool. Similar tool, but like not the same tool, because we were using this tool from the beginning. We end up publishing this, but I forget the name. What's the name, Courtney, of the tool that County was pushing?
The Recovery Capital Index.
Recovery Capital Index. It's a very similar tool, but at the end we agree that we're going to use, doesn't matter which tool, as long as we are measuring that. It's like equally good, but like, you know, if we all use the same tool, we could add much more surveys in this. But this is one of the first published national reviews of using this kind of tool, and I think everybody on this call listening for years about this should take a lot of pride in this. Thank you, Courtney, for pushing for that. But like, you know, Darcy says recently, not only that we follow evidence-based practice, but we are evidence-based practice. So that's kind of exciting time for this group as well.
And I'll talk about this later. So now that Dr. Andrick brought it up, we've had the privilege of being able to see other crisis centers, to learn from them throughout the country who are doing great things in regular mental health. And many of them haven't been as innovative in substance use. So our merging of that with mental health, I think, is really important, and us bringing that expertise into that as a group. And when I say group, I mean you guys as well, because there's been a lot of innovative regulatory as well as housing initiatives in Palm Beach County. So I think we can add that layer of expertise to those systems. And this is part of showing that. Thank you. And just to update, we have this one pager from our federally qualified healthcare centers that gets published every year. We report this information to HRSA. It's just to show you guys that last year we actually saw around 41,000 patients across all of our centers, almost 42,000. And you can see that substance use disorders, I want to point out a few things here. In terms of patient visit volume, patient visits has been about steady from last year. It hasn't gone up, it hasn't gone down. If you look, that 2019, 2021, 22 was like the height of it. And similar to your data, Al, we see kind of a leveling off. Why do we not see a huge decline and more of a leveling off? Because this is a lifelong illness. So patients we've collected are still with us. Yes, some people graduate, but I see frequently patients in the clinic we've known for 5, 6, 7 years, and they just keep coming for different services. Our general behavioral health programs, we separate those out, are actually growing in their volume as well as their capacity. So I'll talk about that in a little bit. But this is just a kind of an overview of all of our all the work that's going on at the clinics. And I love doing mental health care amongst primary care, dental, and OBGYN. It's hard to separate them. So this is a great example of clinical, integration. I continue to want to keep working on social care and healthcare integration as well. And just to show you too, we're tracking, one of our current strategies is to build capacity upstream, which is in the outpatient setting for mental health services, which is what we can do. So compared to last year, we are doing that. We served 9,000 patients across mental health services. In 2025, it was 11,000. And of those patients, there were 32,000 visits, up from 25,000. So just operationally, we're still continuing while we're planning for that new space that I'll talk about in 2029. We're continuing to kind of increase our overall ongoing outpatient care footprint. And when we have that crisis center, we'll be able to plug patients into that system, the lower level of care, so that they don't fall through the cracks. On our operational side, you can see, so the blue bars represent our volumes, our visit volumes for mental health programs, which include psychiatry, integration with social workers in the primary care clinic, mental health professionals, and this includes substance use as well. And I would say at Mangonium, a huge percentage of our patients are dual diagnosis. So you see that we're still overall, over all of our ages and all of our clinics doing behavioral health, we're still up over last year in terms of demand. So the word's getting out. We're trying to meet that demand of the community to be able to take care of any insurance type. And most of our insurance, just to share with you, we have uninsured, which is about half. We also have half, it's mostly managed Medicaid. So we take care of, I would say, underinsured patients as well, because those are very difficult plans to find care on, especially in an outpatient setting. So we take all of that, and then we can take anything anyone brings. I do want to kind of point out pediatrics. So I took that same dashboard and I filtered out under 18. This has been a big strategic initiative for us to provide more access for our young folks. And why is that relevant to a substance use community? Something like 90% of substance use disorders start between the ages of 11 and 17. That's national data. So meeting these kids upstream is part of a substance use strategy to try to be another tool to kind of prevent those kids from getting sick enough that they have to turn to substances to feel better. So we see our volumes for kids going up as well, and our capacity. And we're continuing to grow in that space, especially as we see some of the resources for kids on the acute side, meaning beds and things are starting to decline. So we want to be there to receive that care. And I don't have to, explain this to the group. Everyone knows this, that one of the problems is we did this as a team. Thanks, Al, for setting us all together. But together we were able to disrupt the revolving door of overdose, as evidenced by the stats that were just prevented. So let's do the same thing with all mental health, right? If that was our proof of concept together, we could probably do that with everything. So you all can read the slides. There's still a lot of Baker Acts that are utilized for care. When we think that there's a lot that could be either mitigated in a short-term stay of 24 hours, and definitely on the substance use front. And there's also, so we want to move those services upstream and try to build a system that kind of responds at all levels, kind of like what has happened with substance use here. And so I just want to make a mention of our current programs that are starting to inform our future strategy, and then we'll talk about our future strategy so you guys can see where we are, what we're working on, and where we're headed. So I would say the theme of this slide, and it's a lot of words, I'm sorry about that, there had to be a few of these, but we really, the siloing is the problem. There's so much good work going on in each group, but we have to really integrate with each other to do this work. We are healthcare. Healthcare district will always be healthcare, and we'll stretch that to the nth degree. But we have to have partners in social care, in law enforcement. We have to work with all the groups, criminal justice, that interface with these folks that are high utilizers of hospitals, high utilizers of criminal justice in jails, high utilizers of the social welfare system and the shelter system. I know Dr. Reed is on the call. I work with her a lot on some initiatives to try to improve our working together. So a lot of our current initiatives, the theme is that we're really trying to integrate ourselves with other people. So I'm going to talk in depth about our law enforcement initiatives, and I'm glad Captain Facino's on, or Lieutenant Facino, sorry. Lieutenant Facino is on so that we can go over some of those numbers. But I just want to say we're starting to really get involved more with criminal justice. We've always, through the substance use side, worked with drug court, and we continue to work with drug court and love that program. And we have a lot of success with the referrals that come to us because of the collaboration with drug court. But looking at mental health courts, T1 and T2 court collaboration for mental health patients, we do have 2 reentry programs. We have one where we are sending social workers into the jail when referred to help see if they can help link people pre-release to care. And then we have a relationship with the public defender that if the public defender fights for somebody to get a pre-release psychiatric visit or linkage visit, that they can do it at our Mangonia Park site. So the PBSO officer brings them, and we have a special workflow so that they're, it's private, but they're still kind of safe in terms of being seen while incarcerated. And we're hoping, knock on wood, that those things lead to patients after release kind of linking with us more. We also applied from some of that data. It is really hard post-release to get in contact with folks because even whatever number they listed might get turned off while they're in jail. Those kind of things. So we did apply for a BJA mental health grant, federal grant that came out in March, and we sent in our application at the end of March, hoping that we have something we want to use that grant for if we're lucky enough to receive it, called Operation Tide, that would help with that linkage in between the jail system and our clinics. So more to come if we get that grant, but by writing that grant, we did really develop the program a lot more. I think the other thing is culture development, right? A culture of changing the old approach to mental health care. So what do I mean by that? We're really trying to develop our teams to think differently. So clinical people say, well, this is a clinical diagnosis and this is what I do and this is what I take care of. We want our teams on the clinical side to start to say, okay, you don't know why you're here, you're homeless. I don't want to hear from any of my teams, well, we don't do homelessness at the healthcare district. Yes, we do. It's not the patient's job to give us the answer as to why they ended up in the situation they did. We have to backtrack. We have to take that on as our own, and we have to look at patients more holistically and have a yes culture and stop having barriers. So we're starting that already in our clinic, and you'll see in our conversation about the new facility that we're going to build that in. So what does that mean? Not having a huge medical clearance barrier, saying yes to things that don't sound like your zone, but we're going to take you on. You need help? You're here. Let's figure out what's happening. Let's start somewhere. There's probably some need that we can address. And if not, maybe we have a relationship with somebody who really can. And you came to us, so we're going to own that. So there's a real culture shift going on. And I think also kind of a mutual respect happening across a lot of these agencies to help build the system together. The other piece of this is, and I just spoke about it, caring about homelessness, caring about where someone's going to live. If we don't address people, understand where these people live, who cares about them, and what their purpose is in life, we'll only make so much of a dent, right? Doctors, traditional healthcare systems are really good at stopping the bleed, but then after that is what prevents future bleeds, which is who cares about you, where do you live, and where do you go? So we're doing a lot of things right now with a social referral platform called Unite Us. We do a homeless case conference every month where homeless groups and myself, and that's where I know Dr. Reed, we come together, and Ariana and lots of partners, anybody who wants to come can come. We dissect a case that fell through the cracks between homeless and healthcare, and it's really informative. I'm piloting with a very small target team an initiative called Street Medicine or Street Psychiatry. They have one of these teams in Miami, but there's also a national model to start to use to partner healthcare teams in the street with outreach teams so that the shared goal of getting people housed through that collaboration can happen. We're very much on a small scale with that, but we're just testing the waters to see if that helps us get people back that we traditionally can't get back into our clinics, which include homeless and phoneless patients. And I spoke about peer and care coordination growth. And I said, we're also increasing pediatric access to care, not just in our outpatient clinics, but our leadership team, including Darcy, was quintessential in helping fill the gap right away for the loss of psychiatric beds for kids 12 and under that we lost through JFK. And so Healthcare District, with Darcy's collaboration with Neurobehavioral Hospital and Mandala, Healthcare District gave $500,000 for a capital investment to make those beds and has committed $4.5 million after that unit opens for 12 and under to fill the gap for the first year of the operational business. And it will be assessed year by year. And that is planned to be, a hopeful working partnership until the opening of our pediatrics wing of our center in the future. And as I mentioned before, we're increasing access to care at lower levels. I do want to mention too that I just want to say to this group, this is a little weedy for some groups, but I think this group would find this interesting, that we're doing more clinical Marchman Acts very sparingly. I don't believe in forced care as a regular tool, but if somebody is consistently overdosing or really in danger of harming themselves, we've started doing a lot more Marchman Acts in the clinic. Not a lot, I would say 2, 3 here and there, because most of the time we can engage folks. But we look at it as a tool for those patients who really cannot engage in care and they're really they're in a life-threatening situation. I spoke to a colleague of mine at University of Florida. He said they do it up there quite regularly from the emergency room. And so I think instead of having in Palm Beach County, traditionally, most of the time it's an ex parte order that the family starts. But we can clinically help these families if there's a situation like that to get these patients at least transferred to an addiction receiving facility, and the court case kind of started. It's different than a Baker Act. People can be released from the addiction receiving facility, but at least there's some attempt to kind of build 12 to 24 hours, because sometimes when someone's intoxicated, that's all you need to kind of get their buy-in again, to help save their life. So I do want to mention that we're doing that, and we worked with Palm Beach Sheriff's Office and West Palm Beach Police as well as DAF on that, and it's going well. And this is just a little graphic showing Unitas. So Unitas is a social referral platform that's nationally utilized. Many states have used it to help with referrals across a technological solution to help with referrals across different agencies of different types. So healthcare, social welfare, all sorts of agencies that are assisting with this. Even law enforcement discharge case managers could make referrals through this, so that we start to play in the same sandbox. So we continue to have that contract, and we have lots of licenses, and we're going to be moving forward with trying to get more people onboarded on that system, as well as have it integrated into our own EMR, electronic medical system. State of Florida is also very interested in this platform at the state level. So just to kind of remind everybody of the future strategy, we're trying to help, in our way, influence and build a system that mirrors the physical health emergency and behavioral health emergency, that it's treated the same. And that includes substance use disorders. So we kind of did this with the addiction receiving facility, the clinic, EMS response. But we want to do this for all mental health issues, including substance use. So a person in crisis can call a crisis call center. Right now, a lot of the calls still go through 911, but there is 988, and 211 does have a crisis response capability, and they are deploying the South County mobile response team if there's a voluntary request for it. And we also have the PBSO crisis response team that's coming from 988. But where we're focusing our strategy for the most part is this 23-hour stabilization and short-term stabilization to add to that in our county with the national best practice in line. So let me update you a little bit on our law enforcement initiatives called Operation Coast, Crisis Outreach and Support Team. So we have a police drop-off program where police can drop off at Magonia Park, 7 a.m. to 7 p.m., Monday through 7 days a week. And we've been working hard with this. And this is smaller. We've had ups and downs, and part of this is to learn how to work better with law enforcement. So when we open the big facility, which will be Baker Act receiving, we have a very good working relationship and understanding of where law enforcement is. So up until March or April 16th, which is where our data stops, we just changed electronic medical record systems. We have 236 unique patients and 263 visits. So I'm going to stop there and just kind of talk at high level. This is a highly homeless and phoneless group, as you can see. And so it's a lot of folks being picked up for trespassing. If you look over here, mental health related calls and loitering. So a lot of these folks are unhoused. They live outside or have inconsistent housing. So phone-based care coordination doesn't work great with them. We have a hard time getting them back. And this was one of the biggest reasons we started piloting, kind of going out in the street to see what happens when we go to them, if we can't get a hold of them. So that's something we're working on. I will say that we have a lot of energy. We just made some major changes in March, and we've seen a huge uptick in the police drop-off from mid-March to now. So some of the months in the fall, we had like maybe five a month. March, we met with all the leadership in the law enforcement, and everyone's committed, and we got up to 23 drop-offs in March, and we are at like 16 or 17 in April, which is good because the more we see that law enforcement uses it, each officer, usually the more they tend to use it. So this is great because it's helping us learn what we need to do better with, and it's also helping us continue our relationship with law enforcement. And it's an alternative to Baker Act in jail if that exists. If that's an appropriate response. I just want to mention too, we're getting better and better at getting police in and out in 10 minutes, and that's a huge goal of the program. And most of the patients have severe mental illness too, schizophrenia, substance use disorders, and mood disorders, including bipolar. So that's mostly what we're seeing. On On the Someone to Respond group, the mobile response team that responds to 911 dispatch calls of somebody in distress that has a mental health underpinning, that's still working Tuesday through Friday, although we're talking to Lieutenant Facino's group if they could expand this to Monday as well. We're working on that. This is where they actually go out to the patient who called 911 looking for help. And this one is not as homeless and phoneless. I just want to make a big differentiator. It's mostly people housed with phones. They're very underinsured, but they're looking for help, and many of them haven't been seen before. And about, this, when we schedule them, about 50-50 end up Baker acted or kept in a lower level of care. Prior to this kind of approach, most of those patients would have been Baker acted. And about 56% end up following up with us after the scheduled appointment, which is the same show rate for a new patient who calls our call center. Return visits are a little bit higher return rate, but our new patients, that's about what it is. So this one's been pretty successful. There's been one arrest, and that arrest was somebody who had an open warrant when they called. Most of the patients are agreeing, and that we're getting unit real-time response. So we're seeing success with this program in terms of decreasing the number of Baker acts and arrests and getting good follow-up. But we're continuing to improve it, work on it, and use this data to start to move things along. We will be starting to have a monthly quality improvement law enforcement meeting with top leaders, a lot of the chiefs, probably starting this summer. So I just want to pause for a second and give a chance if there's anything in the chat. That was our current strategy, and now we're going to talk about our new crisis mental health facility called Two Waters. The name was revealed at our board meeting, and I just want to pause if there's any sort of questions about the previous slides. Let's see.
Yes, I had added a question in there about the housing where these people go. Your presentation is remarkable, and what you guys have done and are doing is a testimony to your efforts and your care for the community, and it's really appreciated. And I know it's just numbers, but they do reflect a lot that's been going on, so congratulations. But I did want to find out about any of the homes that you could tell me about, that where people are sent.
Yes. So that's a really great question, and that's something that I'm deep diving. I said Dr. Reed because we have to fit. We are healthcare. That's our enabling legislation. We're not allowed to expand past that. But what we've learned from being with the outreach teams and really caring about the social determinants of health is multiple things. I've worked with Taruna when she was in her position in the past, and lots of great people in the home. Joey Nieves, Lord's Place. So where are they housing? So we think that our role in helping assist the housing piece, which is equally important to what their medication and diagnosis is, if not more, is to first make a proper diagnosis. Because if they're in the bucket of people who could receive recovery residences, right? We often see that the outreach teams who are doing homelessness, they're not able to make that call, and they come from a housing first perspective, which is great too. But sometimes to know that somebody's struggling with a substance use disorder, if it's not totally obvious, is a helpful thing to let the teams know and start to engage the patient at, do our clinical, I guess, motivational interviewing, bring in those peers. We do refer a lot of people to Rebel Recovery who are on this call to kind of engage that person around it, because that's a source of housing. So we do have care coordinators that refer to those places. We also refer from our clinic all the time to higher levels of care. Mandala, we look at their insurance type, DAF, Wayside, all of those places for higher levels of care. And we have had relationships with sober living throughout the years. We have patients who come from sober living that we care for, and we also refer to sober living in Oxford houses and use the online tools all the time. If they're in the bucket of severe mental illness, there's actually not very much for them, but we find that working, if they can find meaning and purpose, that's helpful if they're able to work. If they're so disabled that working is very difficult right now, we work on assisting the disability or SOAR process. And if they're in the bucket, I would say diagnostically of cognitive problems or elderly care, there's a whole different set of housing needs for that group. So those are 3 different groups that have very different housing needs. And then if they're not in any of those groups, we do what we can to support doing supportive housing forums for the county. We keep seeing that patient homeless. We have a van. Dr. Andrick really piloted a van, and it's continuing on that goes directly to the shelters. And we've really made it our business to understand how we can assist these folks in getting housing. If they can repair a relationship, one of our therapists can do a family session to repair the relationship with the mother so that they can go back and live with that person. We'll do that. So to answer your question, Kelly, the homeless population, right, is as diverse as people.
Yeah,
And
I
we
get
do
it.
whatever we're trying to learn all the things and do whatever it takes. We do with the law enforcement drop-offs have the option of using the transition beds that are reserved for law enforcement if they came to us same day for law enforcement. So we utilize that as well.
And I thank you for that answer. I just know that in the past that this has been a conversation that has been tapped into because of certain people out in the community taking advantage of people that are in that bucket of mental health and not really applying to whether they can go into a sober home or a FAR certified place or one of the other more um, overseen facilities, or I don't know, residents, I guess you could call it. So at this, I get phone calls about this, and it's like, these people are so bad. And it's like, I'm so sorry, I can't help you. But because it's not anything but to hear, someone that's homeless, that's been um, in jail, now they're out, now
Yep.
they're put in a place, and the place is just, they're taken advantage of. And it's just, and I know that this is something that the people on this forum have information about and have it in their own heart that this is something that needs to be addressed. But I was just wondering if there was.
Yeah, and you're absolutely right. And some people are very complicated. They're substance use and they're aging. I
Yeah.
see my substance use population that I've followed for years is starting to age, and they're starting to have age-related issues and
Mhm.
substance use, and some of the recovery. It's a challenging thing to solve. So I think your description is absolutely correct. There's still a lot of individual consideration that needs to happen, but this is not helping people with healthcare and housing at the same time is
Yeah.
very hard work. It takes a huge village and it takes a lot of communication. I cannot find a way that's easy, direct to do it. We do need to
Yeah,
share social referrals. And there has to be an accountability to that stuff, that system. I think that would help, but this is just really hard work and it
it is.
requires
And
peers. It requires law enforcement. It's the only way to get to this is to really integrate with each other. And
yeah,
it's a work in progress every day.
Courtney, if I can just
Yep.
be a party pooper, like you and I are late on our meeting, so
I know.
and there is a very valuable information coming on. I would suggest, Al, maybe in the next meeting, we kind of really have comprehensive overview of homeless resources in Palm Beach County
Mhm.
from James Green,
Yeah.
Community Services. I think that would be very helpful. Those algorithms are very complex to navigate anyway, so the more we talk, I think the better it's for all of us. So I would
Yeah.
suggest that we bring that topic as a
I think that's a
separate
great idea.
discussion.
Well, I'll just say with Dr. Green and I mean, also with Lieutenant Fazzino, I mean, we're talking frequent flyers into the criminal system of misdemeanors that they're homeless and they also have mental health and substance use disorder problems. So it's a vicious cycle. We've developed a kind of a quasi mental health court in misdemeanor called
Mhm.
T2. And we're trying to see if we can develop through grants, an actual mental health court in the circuit court for felonies, for more serious crimes. But right now, all we have is competency court. We don't have a mental health court
Yeah.
other than T2, which is a hybrid. So yeah, good stuff for later on that we do need to discuss. But Courtney,
We'll
thank
keep
you.
going.
please do
No
I,
problem.
continue.
I
Thanks, Kelly.
appreciate it.
I could
Thank
talk
you.
about that all day. We really care about it. So I would love to see that next
All right.
presentation.
Thank
So
you.
just to show you, we have the land, it's demolished. Things are actually starting to happen for Two Waters, which is now it's the name of the crisis center. And this is a graphic that just gives you a timeline of how we think things are going to progress. We're actively in schematic design, which leads to design, and then we get a final architecture plan. I'm not an expert in that, but I'm coming to all the meetings and informing it from a clinical place. So we hope in 27 to break ground, and a lot of that depends on permitting and then finalizing construction, and hopefully end of 28, early 29, we have this this sort of central point for all of these problems. So just to give you this is all very draft. I haven't read draft. None of these plans are
Courtney,
finalized.
Courtney,
Yep.
if I can just kind of set the table for this.
Yep.
One of the problems with the addiction stabilization unit, and God bless JFK North, I mean they are serving a purpose still, because they have qualified professionals in the ER. But the original concept is to have an actual receiving facility that can house people, even if it's for 36, 24, 36, 48 hours. But you need a facility that is dedicated and can do that. And when, I'm all for private-public partnerships, but this cuts the Gordian knot for me in terms of once this is online in 2029, economics can't take it away. In other words, if a business model has to shift, like during COVID, which happened with the hospitals, so you lose your partner, or at least partially lose your partner. This won't happen with an actual large addiction stabilization unit in Palm Beach County. I think this is a template for other large counties in the state of Florida, just like the addiction stabilization unit was. And with that, go, please continue.
No, Al, I appreciate you bringing the relevance, because we love our private partners, but we need a healthy ecosystem balance. And I think we've been a little out of balance, as you just mentioned, and this hopefully will strike a balance with the private partnerships that we need to continue. So this is all draft. So we are actively changing and adjusting this, but the shape of the building is pretty similar. So basically inside, it's about 71,000 square feet. We envision neighborhoods, we're calling them, because we want it to feel comfortable. You'll see with the design that even though it's a very large building, we want the patient to experience the smallness of where they're at. You see that there's going to be an FQHC clinic in the front with an intake area. There will be a walk-in 24/7 entrance that gets you to all of these parts. There will be a part of the clinic, as well as a pharmacy and a community partner area. We have a place for our community partners to meet with clients right here. So we hope that they'll be part of this and they can start to see people on the unit. But this will be a police drop-off on the other side, or EMS, that's of Sallyport, but it's going to be very beautifully designed to feel less like a Sallyport and more like a welcoming entrance. But they are still part of the intake process. In the belly of the building, you see that there's two eight chair units that are going to be 24-hour observation units that are locked. Marchman Act, addiction receiving, Baker Act receiving children and adults, and these two are 16 pods. They all can add a little bit more if we have a surge of patients. We've been kind of actively working on that. But these are very open units with courtyards and lots of beautiful aspects to them. We think that the space itself will be therapeutic, lighting, all of that kind of stuff. And then 32 beds. So 8 beds, 8 beds, 8 beds, and 8 beds for a traditional 3 to 5 day stay. Those, we are going to have from soup to nuts everything that you need for under 18. But we know that under 18 has a seasonality to it. So we're able to flex half of the child designated areas into adult if we need more space. You can still do substance use is just one part of this. So people can detox here. They can start treatment here. Nothing will be turned away in terms of substance use here. And the highest acuity will hopefully benefit what I really want to say is that we're trying to do something unique. And I talked about culture, and Dr. Andrick and I are big on this. We even have consultants helping us with this. We want to provide care to the highest acuity and not turn them away because we're not able to take care of them. So the most aggressive, the most substance using, but we want to give them all the recovery kind of approach that somebody gets at a lower level of care. And for the lower level of care, we want to be able to manage some of their medical concerns and things so that we don't have those barriers in place to say, well, your lab is elevated by 0.1, so you can't come to us. That's not the new practice. So we're really trying to make it friendly. We hope that police feel very welcome here and we are going to hold ourselves accountable to a very quick drop off for police. You can see that there's a separate adult circulation, right? And I'm just going to go quickly through this because it has a lot of the same, as well as a pediatric circulation where they don't interact with each other, but it's still in the same building. And this is kind of the look and feel. When we talk about design, we want, function follows form, right? So we want the design to be therapeutic all by itself. It should feel like somewhere you want to be, not institutional. Yes, it's going to follow all the regs for suicide and ligature safe design, but there's lots of national ways to do this in a very warm and inviting way and continue to maintain patients' agency, even though these are locked facilities. They should have choice. Why shouldn't they be able to grab a snack? Why shouldn't they be able to decide if they want to wear their clothes? Why not, right? What's the big deal? So kind of really trying to deinstitutionalize, but still be able to offer care to the highest agitated folks, and with the best medical practices. That's what we're going for. So that's a little bit about the physical space, and let's talk a little bit about the inner workings of this building. So SAMHSA has made definitions. They have a book called Definitions, and we're following that. We're not making this up. I just want to say about this slide that a perfect system of crisis has all of this here. And you see residential programs, respite programs, those are extremely important, the blue and purple, and we won't succeed if these aren't put in place somewhere in our community. But our facility is focusing on the dark green and the light green. That's what we can offer in our enabling legislation, and that's the piece of the pie that we're offering. We hope that this starts to other places are starting to do this. They exist in certain areas. In the substance use world, there's lots of residential facilities, and those are fantastic. And we need those to stay in place because that's where somebody's going to get that 30-day residential experience. But on the mental health side, there could definitely be more of this. And I know South County has a wonderful residential, but maybe more of that would be helpful, right? Those longer term, lower intensity facilities. But we're going to be focusing on green and light green. So you see that we'll be able to do anything a hospital can do, a high intensity, but we also can do voluntary, mid, and low intensity. And honestly, with the clinic being there, we envision being able to do sort of like urgent care type things. So there's a lot of patients who need that urgent care model for mental health, just like you have for medical outside of their outpatient visits. We're exploring and not sure now if we would have IOPs, PHPs, and things like that, but we'll go where the gaps are that we can do. But as you can see, when we talk about merging medical psychiatric culture with recovery, peers are probably one of the biggest parts of this program, even though we think it's going to be probably licensed as a hospital under our Lakeside hospital license. So these peer specialists, therapists, case management is a mainstay, as well as techs to this facility, more so than nurses and doctors. Yes, we need those roles as well, but peers are going to be a huge part of this place, as well as community partners having the access to come in when invited to those higher levels of care to say, where are you living? I'm here from Oxford House, for example. I know that you can get into Oxford House. Let's coordinate that and keep you here until that transfer can happen. So that's part of our need to really stay involved with all these other agencies. The treatment is started with the assumption that things can be resolved. They will be resolved. So the team has to change their whole dynamic of where's the bed and how do we board them? In a traditional inpatient side, you say, okay, you need to be admitted. And what happens? People get boarded in ERs waiting for a bed for 1 day, 2 days, sometimes 3 days, depending on the population. And nothing happens in that 72 hours. That makes no sense. So the new model and the national model says you have actually a metric called door to psychiatrist, door to therapist, door to peer, and they have to be quick. To be effective, this all has to happen within 2 hours. So treatment should start as soon as they get there. Even if you, in the beginning, can't lift a Baker Act, you might be able to 16 hours down the road when a peer's gotten them to soften. Maybe they wanted to convert to voluntary. So that is the goal. So we need to have this stuff set up right away, and it has to be very quick and intensive, and that's the change in culture. And we want to move people towards the least restrictive care so that we want to assume that most people are going to be discharged to the community and most people will be converted to voluntary status. This is a picture of one of the biggest places that started this movement was in Arizona, in Tucson. We had like Dr. Andrick and I, it was like a celebrity following. The woman is Dr. Belfer. She spoke at our strategic planning, but she really has pioneered a lot of this. And their facility is just as big as this, and 50% of the patients that come to the facility are law enforcement drop-offs. And we rode with law enforcement who said, we love it because we're in and out. We're in and out. We're treated so nice here. 50%, they're not coming from EMS, they're coming from law enforcement. So they have law enforcement that's willing to drive 3 hours because they know they'll be in and out and something will happen with that person. So we really need to make this law enforcement friendly. We're going to have a nice space for them, a bathroom, but also the biggest thing is we're so happy you're here. Bring us the patient. We'll take them over and take that off of law enforcement. We can't ever tell doctor, well, they're to this or they're to that. No, they're for us. The answer is a yes culture. We're going to try to take it down and have people who know how to de-escalate as well as engage the person. And the core philosophy, right? I keep talking about culture because I always say the building is amazing, but it's what's happening on the inside that matters the most. We need to develop a culture that's very different. Safety is not control. Safety is not control. We are not going to have security guards at this facility. They don't have them at any of the others nationally. They're going to have one in the parking lot, but we're not going to have them as a regular part of our inside of the building team. Voluntary support first, return control quickly. So even if we have to restrain someone, which we would be able to do, how quick can we get rid of that? How quick can we change that? One place we visited in Kansas City had a teenager. They said he was flipping over the furniture. And the leader there said, I had a kid yesterday flipping over furniture. We didn't restrain him. I just said, do you want me to help you flip it over? Let me help you. And the child de-escalated and was like, you're really going to do that with me? But that's such a different approach to this kind of like behavioral approach. And we're going to really try to live that. Hope is clinical, relationship is intervention, and practical and emotion support go together. And so people need to be heard and respected, supported, empowered, connected, not controlled, and hopeful about the future when they come to this place. We are really, really invested in that. We have consultants who think very differently than us for good reason. They're helping us think differently about this. So at the end, the national data from this, here's the reference, says that when you have a facility with this culture and this kind of build, you resolve 81% of the people brought here by sending them back to community care within the 24 hours. And this, if you look, a lot of these patients ended up in SUD treatment, detox, or psych hospital. Interestingly, most of the places we visited have done a great job doing this with mental health, but they haven't with substance use. And I think if we marry what we've learned in Palm Beach County, we can maybe even improve on this. And most people were connected to care afterwards. So this is a very important thing that we're aiming for. And finally, this is a slide taken from one of our speakers, but I think it's beautiful, which is early intervention, postvention, prevention, and response. All of these things have to be working together. So this meeting is a great testament to that on the substance use side, but this has there's so much work here. There's room for everybody's enabling legislation mission. And we just have to talk, we have to communicate, and we have to all believe that as we each build our parts of this, housing included, we can really make a dent in our community and change the whole dynamic of this, of not just substance use, but mental health and hopefully prevention for kids. I really appreciate your time and thank you. And just want to know if there's any questions.
If I can just add, Courtney, before we see if they have, this is like very transformative care in psychiatry. This is how modern psychiatry should look like. So we are not reinventing the wheel here. We are trying to copy the best practices because we believe that Palm Beach County residents deserve the best practices. Like all of us on this call have a lot of privileges in many aspects of our community. We know we have connections. I know all of you, I can pick up the phone. But still, when my neighbor had a mental health crisis and her husband asked me where to take her, I didn't know what to tell her. So those are the things that, like, you know, we are trying to address, that we have easily recognizable, good quality of care access, that everybody knows where to take their loved ones or family members, because we are all touched by mental health crisis. And this is coming from mental health crisis, right? The SAMHSA is coming with those guidelines, how you treat community as a patient when they have, when their illness is lack of access to mental health care. So we are trying by the book to apply what national guidance are telling us, how we can treat psychiatric care, how we can provide the best psychiatric care and get the maximum of our resources. So how we can get the best return of our investment. This facility is just the start. We have a lot of work to do, as Courtney said, upstream, like 988 call mobile response team. More than anything, post-care, what happened after the crisis, right? Because one of our key indicators will be what percentage of those patients seen in the crisis will return in the crisis again. Our goal is that they never have a crisis again. And that's a very ambitious plan. But as long as we are here, we're going to try to do that. As Al said, we want to see 0 overdose. We know it's kind of really high goal, but we are all not giving up because it's a very ambitious goal. So that's similar to this. We don't want to see people in a crisis in this center, but that depends only of those 3 Ps that Courtney talked: people, place, and purposes. What's their purpose in life? Where do they live? Whom they socialize with? What kind of support they have? That's equally, if not more important, of injection of Haldol or the therapy that they receive or disability that they receive.
Yeah.
So those are the things that are in this project are equally important. We strongly believe that culture of this facility, and we believe because those are evidence guidelines, right? So if people react how you treat them. If you put them in handcuffs, they're going to give you aggressive behavior. If you treat them with motivational tools, that you treat them equal, and then you understand that their agitation and extreme of their mental health is actually psychological pain. We are very sensitive to if somebody has a kidney stone or gallstone pain and end up in emergency room. We are not really very sensitive to psychological pain that suicidal patient or acute schizophrenia feels. So this center will treat those acute mental states as the highest acuity pain in medicine that some human being can experience. So the culture has to change. All of us, we have to change how we think about all this. And good news is there is a lot of guidelines that we have to follow.
Yeah, and thank you, Dr. Hendrick. I just want to respond to Terry's question about we actually visited Judge Leifman. We've spoken to him, really trying to get inspired by some of the things going on there. Long-term funding, you're right. Clinical sustainability and financial sustainability have to go hand in hand. We are very, I think we are called to take care of our insured and uninsured, but there's a lot of cost savings on the criminal justice side when you do this. So we have to show that always. Everybody who's dropped off here isn't being dropped off to jail. There's probably a huge cost savings of that to show the value. We have to approach payers if the outcomes are better and start to, negotiate contracts for the insured patients coming to this. And we have to do it efficiently. And that's, I think, where the recovery world is also very helpful. So there's a lot going on with financial sustainability. That's not an easy, quick answer. But that is as much a part of our strategy so that this stays open long past Dr. Hendrick and I's tenure, as the quality continues to improve. So I think the quality will also help dictate or maybe influence some legislative of how you reimburse some of these services. So it might inspire this to continue to happen more. So that's a very hard question to answer in a very packaged amount of time, but you're absolutely right, Terry. It's like as much on our minds as the clinical quality. And
so
the
Judge, I'm just going to add, Judge Leifman is our idol. We learn a lot from Judge Leifman.
Yeah.
We hope that our chief or judge, when time is right, really help us to establish mental health court from our facility. We discussed that in design. We visited facility that has mental health court, but now everything is online. So everybody's discouraging us to kind of create a special space for that. So one of our conference rooms will have a flag and all telemedicine equipment that we can kind of easily perform the remote access to the court. But we did a lot of tours of all those facilities, and we are trying to learn from their errors, because our facility is really unique in this aspect that we are trying to fit both adults and kids. as well as outpatient and inpatient. Our priority, because we have such a limited access, our priority that this is a one-stop shop for many aspects, so that that we really have all doors that we need in that acute
Yeah,
case.
which also includes a huge private list of providers. We need the private providers to stay in the space they're in. We're gap fillers. We're not here to replace that. So we want to also support the private community in continuing what they're doing, so they stay open and continue to do those things. We need that. Thank you all so much, and thank you,
Al, I
Al.
think you're mute. Al is talking.
Oh, you're muted.
I said, thank you, Dr. Phillips. Thank you, Dr. Andriek. That was inspiring. It's really great. It also cued in my mind. I see Lieutenant Fazzino is on the meeting, and I think that it's time for PBSO to be a part of the task force, as well as we used to have Houston Park with fire rescue. Then he was DOH, and now he is MIA. I don't know where he is. But we need to bring on DOH, fire rescue to be actually a part of this, so that there'll be somebody who can report up the food chain as well as PBSO. So Lieutenant Fazzino, you're with us. So if you could go up your food chain and see if that's something we can do, either have you or whoever Sheriff Bradshaw designates, that would be great. The next meeting is June 10th. I'll talk to you offline about it.
Okay. I don't think it'll be an issue. We just got to have that conversation.
And right now, there's a 3-minute video. It's just a couple of minutes. And this is not a technical video. This is more of, of an inspiring video, and very 10,000 foot, so I was debating, because we don't like to do videos like that. I mean, the last one we did was DAF. That was a little too long, but it was good. It was worthwhile. So if you don't mind, Dr. Phillips, Dr. Andriek, we're going to play the video.
Yeah, and this shows how we got our name, and what it really, I think, speaks to the culture inside, the approach to the patient.
Cultural video. That's what I was trying. In so many words, I was trying to reach that. So let's go ahead and do that.
Is she gonna put it? Because otherwise I need my screen back.
Oh yeah, we need the screen back.
Oh yes, please.
Yeah.
Thank you, doctor.
The name Two Waters is more than a location. It's a heartfelt promise to our community. Nestled between Lake Okeechobee and the Atlantic Ocean, our facility stands between two very different bodies of water. One serene and gentle, the other powerful and thunderous. This meeting of waters isn't just a geographic truth, it's a reflection of our shared emotional journeys. As humans, we all move between peace and storms. At Two Waters, we will offer a haven founded on empathy and understanding. Our property features 2 retention ponds, like quiet guardians that protect the land we will call home. These ponds can be seen not only as landscapes, but as living symbols of how mental health care can transform lives. Just as the ponds hold back floodwaters, so too does our care help people manage overwhelming emotions. Left untended, water can bring destruction. When held and directed, it brings life. In the same way, when our feelings are met with kindness and support, healing can begin. Water resonates deeply as a metaphor for the human experience. Within each of us, there is an ocean of memories, dreams, and fears, sometimes still, sometimes wild, but always alive and moving. The world around us reflects the world within, and Two Waters is where these tides meet. Here, we invite everyone in our community to find both shelter and renewal, a place where the healing of mind and spirit flows together. Water is life, and so is mental health. Both are essential. Both sustain our community, our families, and our dreams. The name Two Waters is our pledge that together we can weather even the roughest storms. With compassionate, respectful, and evidence-based care, no one has to face those waters alone. Here, hope is always within reach, and every person is valued, cherished, and supported just as they are.
All right, if there are no further questions or comments, we'll go on to the next item on the agenda, which is I'm proud of the county. I'm proud of how far we've come, me personally, as well as my office. We've been 10 years into this process as of July. The process first of the Sober Homes Task Force, and now the State Attorney Addiction Recovery Task Force. I know that we didn't talk numbers with regard to the Two Waters, and I know Healthcare District is taking on shouldering most of the economic burden, but the county also stepped up to the plate with some dollars, significant dollars, for the project. And this is another county innovation. I believe, and I'll leave this up to Dr. Joanna Reed and Noyes. And Doctor, you're going to have to tell me how you want to be addressed, because I heard Dr. Reed earlier, and I don't know. So having not met you personally yet, but I applaud the county. I believe we still have Commissioner Weiss on. He has been a stalwart for years, and then commissioners before him were also involved in the process. And it takes all the silos, and the county is a very important silo in terms of our locally addressing the issues. So without further ado, and how shall I call you, Doctor?
Dr. Reed, Dr. Reed Noyes is fine. I guess once you're married, you try to keep both your maiden name and make sure that your husband's last name gets in there. So Reed and Noyes is fine, or Noyes, is whichever. But thank you.
And you're going to, if you have any preliminary remarks, but you're going to, you have a presentation for us?
Yes, I do. I will be sharing my screen here. Thank you, Dr. Fellis and Dr. Andrick, for that wonderful presentation. We understand the importance of having a crisis center here in Palm Beach County, and you're very forthcoming, and I'm looking forward to 2029, and hopefully, we will have, despite of what's going on in our housing space, that we will still have sustainable programs to assist those who are coming out of crisis and going into recovery and having those supports. One of the initiatives that we just launched here in Palm Beach County is the Recovery Housing Initiative. This initiative is funded through the opioid settlement dollars here in Palm Beach County. And what this initiative is intended to do is to support individuals in Palm Beach County who have a substance use or co-occurring disorder by providing a safe, stable housing or recovery housing option. And so this is aligned with our master plan. Back in, I would say, when I started with the county in 2020, we launched we had a pilot program, which was called the COSUP, and it transitioned to COSAP, where individuals who had a criminal history and a substance use or co-occurring would be provided with recovery services through Rebel Recovery. And we were able to launch this pilot program and have this a research conducted through FAU. And we found that housing is a key predictor to long-term recovery. And so, along with peer supports and care coordination um, and other supports. And with this, we wanted to scale this on a county level, in which we do understand that, when it comes down to recovery, housing is very important. And so currently in our opioid settlement funding dollars, 90% of our funding is allocated towards social determinants of health, and 10% is allocated towards deep end and crisis care. So with that being said, we're really heavily invested in the social determinants of health, which in that you would have housing. There's also employment, recovery support services, and also other areas in which we are currently invested in when it comes to SBIRT, education, and so forth. And so right now we will focus here on the recovery end, and we decided to go into this space to support those who are in recovery and providing supports for housing. So we do understand that individuals who are experiencing a behavioral health substance use, they interconnect with many systems of care. They're in our criminal justice system, they're in our homeless system, they're coming in and out of the hospitals. There are veterans, there are elderly, and even our Alice everyday families here in Palm Beach County. And so individuals are in different systems of care, and so is recovery. So when someone is in recovery, they are also within these systems of care. And so we have to ensure that there is a no wrong door approach when someone is coming in to any of these systems of care. How do we connect them to services right away so that they're not getting frustrated and having to re-traumatize themselves and so forth. And so we're really working diligently on this and trying to integrate our systems. And I'll talk more about that later on. And so that anyone coming through any of these systems are connected to resources. And so I really wanted to bring up this study in which individuals who who are in recovery have, 32% of them have housing instability. So we do see that housing is a key predictor. It is a need here in Palm Beach County. And we understand that affordable housing is very scarce here in Palm Beach County. And so what are we here to, and I'm actually in a HHA planning meeting talking about affordable housing and what may come down the pipeline for HUD. However, in this space, this is just transitional, this is temporary. And so going back to the COSUP study, individuals who were provided housing for up to 6 months were able to improve their recovery capital. They were able to decrease recidivism. And so we do understand, again, that housing, peer supports, care coordination, building community connection allowed was able to help individuals increase or achieve long-term recovery. So with this particular initiative, this is helping those to get connected to recovery residents, particularly FAR certified homes and or Oxford housing. We will be expanding to housing stability outside of that. That is part of the plan. However, this is financial assistance up to 3 months for transitional recovery housing. And also in this space, the individual must have some type of peer support, case manager, preferably a peer support, because we do understand that those who have a peer support have a higher chance of achieving a long-term recovery. So in terms of the requirements for this particular assistance, as I stated before, they must be FAR certified, Oxford housing, preferably the housing in which they are being placed at is MAT. We do understand that currently our FAR certified housing right now, they are MAT. They do accept MAT, but there is a legislation, I believe, and correct me if I'm wrong, Al, that this may go back to where it was before, where they can choose whether or not they would want to accept MAT. And so this allows us to ensure the quality of the services that are being provided in these within the FAR certified and Oxford housing. As I stated before, they must have a substance use co-occurring. they must have an individualized plan. Okay, so individuals who are transitioning into recovery or going into recovery, they must have a recovery plan uploaded, and I will go over that process. We are requiring, or we're hoping for them to, and I understand there's a study with BAM, but we would like to measure their recovery capital, seeing, how they're doing prior to housing and how's their recovery capital thereafter. And so we will do a study on that as well. And so when it comes to the process, there are a certain number of providers that have access to this. So this is limited funding. There are a certain number of providers currently who has access to these dollars. They have a budget line. And so when a participant is working with an approved provider, that provider will then pre-screen the individual to ensure that they are ready for a housing, because you need to ensure that the placement is the right fit for them. They'll then go into Oscars and apply on behalf of the client. Now, at this time, the provider will need to have have selected either a FAR certified home or Oxford home for that client, so that when they do go into Oscars, we'll have that individual or that vendor into our system, and then we'll then support that individual for up to 3 months. The current providers that we have in this are Saartf through the Connect program. We have the Lord's Place, Rebel Recovery, Wayside House, Drug Abuse Foundation, Hanley Foundation, the Hub, Compass, and we just expanded it out to the Public Defender and the Reentry. So again, this is a no wrong door approach. Saartf is really working with those high utilizers, those who are going in and out of treatment, and just can have a high reoccurrence, and working with those individuals. The Lord's Place, they're working with those who are unhoused, who individuals who may be unhoused but are on their recovery journey. And so that's within the in-housing instability space. Rebel Recovery, they work closely with the CJ involved and with the unhoused as well. And you have Wayside, Drug Abuse Foundation, and Hanley Foundation. They're more on the treatment end. So individuals who are leaving treatment and who would like to go into a recovery housing. The Hub, they're just a really important in our community, where no matter what walks of life you're in, as long as you're within your recovery journey, they're assisting those individuals. And with Compass, they're assisting those who may have an infectious disease, or anyone who they're specifically targeting the LGBTQ community and so forth. And so providing behavioral health services. And lastly, we have our Public Defender Reentry for those who are coming out of the criminal justice system. This can be expanded. These are the providers at the moment that we currently have a county contract with. And so this ensures that the housing in which they are providing, they are also providing services that are covered through county contracts. As far as future developments, we are looking at a bed utilization. I remember Dr. Phillips is talking about, how do we know there's a bed available, and trying to connect those who are coming out of any one of these systems and connecting with the bed. So we're looking into expanding our Oscars module. Right now we have a smart landlord. And so we're looking to expanding that into the recovery housing space and looking at bed utilization. And so we're working with FAR, and I want to give a shout out to FAR, great partner in helping us in connecting the providers to this initiative. We're also currently working on our data warehouse, where this will allow providers to have access to, how can they, if they would like to better care coordinate with, their team on the social services end, they'll be able to go into Oscars and see which area within the system of care has the client interacted with, to better help them with their care. We are also having a landlord, or what we call vendor portal, where even the recovery housing vendors will go into the portal and they'll be able to see where their payments are. And this is more transparency on them, so that they are aware of, where the payments are in the queue. So that helps to secure the financial aspect of placing someone in their home. And lastly, expanding to a safe and stable housing. beyond the 3 months, because we are supporting up to 3 months due to the limited funding that we have, we do understand that we want to move into the permanent and stable housing space. And so we're looking at alternatives and options for that. So our program coordinator is currently connecting with landlords to see if they are able to be open to placing someone who is in their recovery journey and to placing them at their home. And so we're really looking into that safe and stable housing options as well. However, the ultimate vision here in Palm Beach County is the recovery village. So we haven't lost sight of the recovery village. We are looking to go out in a NOFO, trying to see what that would look like. And so we do have set aside dollars. Right now, it's about $3 million of accrued interest, which we are going to go out to bid for, to hopefully get an applicant who is open to developing this recovery village for individuals who are in recovery, which will include, subsidized housing options, and also, what you see here, a fitness center, somewhere where they can get employment skills and so forth here in Palm Beach County. And so that's our ultimate vision. And I also wanted to bring up that on April the 28th, this is our second session. Our first session was on April the 2nd. We had a very successful Recovery Housing Network event at the hub in Riviera Beach. So April 28th, we will be hosting a Recovery Housing Network for any recovery housing, Oxford housing vendors who looking to connect with the county to become a vendor. We will host this at the hub in Lake Worth on April 28th from 1 to 3. There's a QR code, and we've been able to reach out to FAR, and they were able to email their network. And so we're very fortunate to have that partnership. Here is my contact information. The program coordinator, Jacqueline, she's the point of contact when it comes to anything regarding housing. We've also expanded, or we have funding for transportation for those who have behavioral health and co-occurring. This is on another budget line, so we're able to expand transportation to those who are in need of that. And there are specific providers who have access to this, but we're really looking into the social determinants of health and how do we best connect individuals to these resources. Thank you.
Thank you, Dr. Reed. Any questions or comments? I had a question or two. I don't know whether, and I apologize if you had mentioned the commitment to the county. What is the dollar amount? What's the length of the commitment?
In terms of the opioid settlement dollars?
Yeah, in terms of the housing, this housing initiative, and what you're carving out from the opioid settlement dollars.
So based on the budget from the original budget amount that we have here, we had about $900,000 in this particular line item that was carved out for housing. And so that's the approximate number that we currently have in this space for housing, but social determinants of health in general, okay? And so particularly for this area of the recovery housing is about $500,000. However, there's some dollars within the Connect program that has housing as well. So I would say roughly about $600,000.
Right, and the Connect program, do you mean the SEFBEN's voucher
Yes, through
program?
SEFBEN. Yeah, so SEFBEN has housing dollars, part of their contract. It is also being routed here through the county. They have set aside about $300,000 in their budget. And then in our current budget, here we have about, I would say 450, so about 750,000. However, keep in mind that we are getting transfers from other I would say municipalities that have transferred a lot of their dollars to the county. So we're going to look at the budget again. We've also received other settlements that have been transferred over to the county. So we need to relook at the budget again to ensure that there's 90% within the social determinants of health and another 10% within the deep end. And so with that being said, within the 90%, majority of those dollars have been allocated through our NOFO process, and that's not until 2028. So when those contracts are ending or close to that point, we can revisit looking at the budget again and probably set aside more dollars. And that is where our advisory committee will come into play, providing recommendations for the next round or funding cycle. So right now we're working with what we have, left within that line item.
So not to give a specific amount, but the funds will be, the process will
Yes.
be in place to distribute funds that are appropriate. When would that begin approximately? Is it online now? Would it be in July, October, the next fiscal budget? What do you envision?
Are you referring to the recovery housing or just the opioid settlement in general?
Well, I looked at Recovery Housing Network as being one and the same with the opioid dollars.
Yes. Okay. So that's available right now,
Okay.
if that's what you're asking. So we're receiving applications as we speak for placement and from the providers that you saw on the screen, and we're processing those applications. So we are, we're right on it. And these providers have been placing individuals in housing, but it has been more on a reimbursement aspect. Now we're trying to streamline everything into Oscars because we're trying to see where the dollars are going and trying to stop any potential duplication and just making sure that our resources is being spread out and throughout our system of care.
Okay. Another question is, and I think you answered this, you're only dealing with certified recovery residences and Oxford houses, correct?
At the moment, however, we are looking to expand that because we do understand that there are some restrictions, and I just had a conversation yesterday with Saartf with some restrictions with individuals who may not be able to go into a FAR housing due to specific offenses. I have to look more into that. Sexual offenses, and they're in their recovery, and we're really trying to work with these special situations because, regardless of where they are coming from, the system of care, if they're on their recovery journey, we want to work with that individual and make, help them. And we want them to succeed. And so there are some special situations that we will be working with, and we're relying on our providers, right, to advocate for those special situations. So, there's some leeway around there, but right now we are focusing on FAR certified Oxford housing, but there may be some outliers here and there where they may not be able to go into that. And so we may look at other options and see how we can best support that individual with their recovery.
Okay, thank you for that.
Yes.
The one comment I would make is there's an incredible need. And that's great. I said earlier, it's great that the county is stepping up and becoming part of this multi-silo solution. I will caution you as you look into non-certified or non-Oxford House recovery residences or even places to live. There may not be any oversight. And I know that Saartf
Right, and I understand that.
only voucher to certified or Oxford houses. At least that's what I believe most of the managing entities, if not all, for that very reason. So, it's a cautionary tale. Some people are on this panel who have been with us for 10 years and can tell you what some of the horror stories of having no oversight whatsoever.
No, we definitely, I do agree with that. And so it is definitely not the go-to, but we do understand special situations and,
When you said landlords,
Okay.
my
No.
antenna went up. Okay, and I take it that you, like Saartf, you would be, it would have to be MAT friendly. In other words, all forms of MAT, because that's science, that is the current best practice in terms of SAMHSA.
Absolutely.
Okay,
Absolutely.
And lastly, it's interesting that you bring up the Recovery Village because it's going to segue into a kind of a brief discussion on what we've been trying to do for 3 years, which is to change the law in Florida so that it makes some sense in a zoning context with regard to allowing, as of right, recovery residences and Oxford houses with a modest distance requirement, and then have a reasonable accommodation, which is the only thing available now in most jurisdictions, but have a robust, reasonable accommodation for those that are within that distance. When you talk about a recovery community, there is such a thing in the in this prototype legislation, which I'll send to you. I'll make sure that you're all aware of it. And
Okay.
you're going to hear a little bit about it, but not much right now. And it is in the handouts or the attachments is that statute. And we do have Dan Lauber on the meeting here, who actually did a study for the state of Florida, which was paid for through through FSU, Florida State University, on the best practice or the best way to be able to expand the number of recovery residences in the state, while also paying attention to the municipalities and local counties in terms of factors of clustering, for lack of a better word. So anyway, I love the idea because that but have you thought that out? Is this a living community? Actually a recovery community where it's not just a place to go like the hub, but the houses are attached to it.
So, I have to, I can't do this without, successor John Hewlick, John Hewlick's vision and in this recovery village, and it's also in our master plan. So we're doing, we're going to go into doing a little bit more research on this because it is part of our master plan. And, our advisory committee and the community's input has, it's literally from the bottom up has been throughout our master plan. And so this is part of our plan. It's something we're going to look at. I don't have any more information on it because it's something that, we're trying to see, is it feasible here in Palm Beach County? I do remember when I was working under John and working with John that there was a potential land in Riviera for this recovery village. Now this land has been sold, but I believe he was working very diligently with developers in getting this done. I just have to go back and see where in the process, and is this something that we can do here in Palm Beach County? But I didn't honestly hear anything about any restrictions. From my understanding, from listening to our conversations, and remembering these with John, it was more so of think of a 3-story building of a mixed use housing with on the first floor, you would have retail stores and community center and so forth. And then 30%, or I would say 50% would be for those in recovery. And the other one would be so it would be mixed use. So that's the conversations I've been having in the past with John. We just have to go back and look at that to see if that's something.
And you would also have a designated piece of land, so you might not have that neighborhood issue. I see that there's a hand raised, Jeff Lynn, as a question or comment. So, Jeff?
I thank you. I just wanted to get more information when I saw the slide about recovery community, and then Al chimed in. I just want to be clear that when we use the term recovery community, like all kinds of words matter. And in my experience in this space is that we're all trying to do the same thing, but we throw out terms, not recognizing that they have a previous designation. So they mean different things to different people. And what I've learned in this space, in being a liaison between governments and regulatory bodies and the recovery community and the treatment industry, is that I have to play translator the best I'm capable. And a lot of these things don't translate. So that was my question. I didn't realize till you spoke, Doctor, that this was a John Hewlett originated thing. But as a zoning attorney and a regulatory attorney, I was going to bring it up. I'm not just speaking out of turn. This is fascinating, and I heard from um, Al that Dan Lauber was on this meeting, and Dan has taken the term recovery community and just applied it to multifamily apartment buildings as like a zoning term, which is great. That's fine. But when you say recovery community in the photos that I saw, it looked like a mixed use project, which is exactly what is awesome. Yes, that's you're creating a recovery community as opposed to one that was organically created, let's say like City of Delray Beach. Has been there longer than a lot of people were alive on this call. And that's an organically created community of people in recovery, as opposed to what I like, and that's why I wanted more. Reason I raised my hand was to get more information, and then we can take this offline, perhaps. Is the mixed use kind of project. So I asked Dan Lauber, and if he's on, he can respond to this because I think this is a great conversation. I said, to rather than spacing, how do you create? I asked him, how do you create permissive zoning? How do we create zoning in such a way where we encourage and incentivize developers or people? Now, I don't think it's going to happen with money. I think it's going to all be public money. Side note, I don't think this is a private industry kind of thing. You never know. But how do you create that kind of zoning? And there was a long pause by Dan. And again, if Dan's on, he can respond for himself. I don't want to put words in his mouth. But his as a land planner and a lawyer, his suggestion to me is it's not possible. I mean, it is possible, meaning from a governmental lift, from a popularity lift. So, and I heard you say the word master plan. So if this is something that is legitimately being looked at, I would love to help get ahead of this for no other reason, but you can have all these great plans and then you submit it to wherever the jurisdiction is that does the zoning, and they're like, you can't do this. So why? Because there's people in recovery there. And you say, yeah, so, what if I made it for a different group of people? What's the difference? This is just 15 years of civil rights litigation and more 20, 30 years, making my non-hair stand up. Okay. So the only reason I say that is, Al, is if this is something that's real and that you said the county's giving money behind and there's things behind, I really think that this is a topic that this specific task force needs to address on, because we did start as the Sober Homes Task Force to deal with recovery housing. And all I heard was a great presentation right now on the needs for recovery housing and the needs for all of this and social determinants of behavior and location. I mean, that's what the whole meeting's been about. It's been great to be back with you, Al. But the last speaker, this doctor, is so on point that I think that this task force needs to really get behind that. And that includes creating spaces, giving the real estate so that these people can exist in their own communities however they want, rather than what, we'll talk about. You said in a second or two about Chapter 419, how it seems to do inclusion by segregation and separation. And that's not what this is about. I want to get behind this recovery community. I think it's a fantastic idea. I think it's long overdue, and I think Palm Beach County is the absolute right place for it. Thank you.
Hey, thank you, Jeff. Before Dan's got his hand up, Dan Lauber, this is an interesting issue, and because you mentioned it, and I know it's not a fully developed project, quote unquote, I think it's something we all on this in this meeting can get behind, and it may be a wave of the future in various governments who have the ability to dedicate a parcel of land. I don't want to get deeply into that discussion, so we can come back at a later date at a later meeting. But I will say you may want to have some people be able to chime in to your process, people like Jeff Lynn, people like Dan Lauber, so that you can get a sense of the zoning issues and the lack thereof. I think Dan, I'd like to hear from Dan, because if the land is if a mixed use specifically for this purpose, it does, again, I'm going to use the phrase again, I love the phrase, cut the Gordian knot in terms of community as opposed to recovery. Because you're dedicating a usage in a parcel of land, so you don't have the neighborhoods within that parcel that are going to come with their pitchforks and torches to zoning meetings and scream and yell. So this is all great stuff. Dan, would you would unmute yourself and let's hear from you. This is a great
Okay.
segue to the next piece, though.
Yeah, that was very well done. Uh, if what Dr. Reed Innois is describing this three-story building with mixed-use housing, 30% of the units for people in recovery, that is a recovery community under the definitions that we've been using with the cities and Palm Beach County itself, as well as in our draft legislation for 419. Fits it perfectly. So, I'm happy, Doctor, if you'd like, you've got a copy of the draft state statute in the packet for today. It still has 9 changes that need to be, technical corrections that need to be made. And the study would probably be very helpful for you. You can download it from my site, grouphomes.law. It's the latest incarnation of it. If your browser tells you the site's not secure, plow ahead anyway. The security certificates just don't work. Do not try to read it in one sitting. It will cure insomnia. But break it up. But you'll see that what you're proposing does fit the model definition of recovery community that's in the proposed statute and in Palm Beach County zoning that we worked on. It does envision mixed-use buildings. Nothing to preclude them at all.
Okay, thank you, Dan. We will, I mean, this is a great discussion, because again, this is in progress. I mean, we have needs. We're trying to get the needs and thread the needle. You guys, I really want to hand it to the county for stepping up to the plate and being a part. And also a shout out to John Hewlick, who has dedicated his working life to these issues, not only in Florida, but also in New Jersey. And he deserves a ton of pats on the back. Any other questions or comments? Angie, from FAR,
Yes.
you got your hand up.
Yes, thank you. So my comment goes back to the initiative. Dr. Reed, thank you very much for the presentation. Where you mentioned the FAR certified recovery residences and the Oxford houses being the eligible recovery residences for the funding, and that it might be opened up to other recovery residences because FAR certified recovery residences have restrictions on the residents. I just wanted to clarify that FAR does not have restrictions. Maybe providers themselves have restrictions, but we do want to open up the door to have further discussions offline about that and maybe invite you to look at what our requirements are for FAR certified recovery residences to actually become certified, because as Mr. Johnson had mentioned, it would be like a slippery slope to invite non-certified recovery residences to receive that, the funding. So I just want to make that available to you before you make that decision.
Yes, thank you. This was just
Thank
a
you.
request. Thank you. I will definitely reach out because this was just a meeting just yesterday about a request. And
Yeah.
and I wanted to, and I'm going to reach out because it's an individual with a sexual offense. So I'm not sure if that's a FAR thing or if it's more so that provider, maybe it's the location of the provider.
Exactly.
Okay.
Yeah. It
Yeah.
could be anything like that. Yeah.
Yeah.
Thank you.
All right. Thank you so much. Dr. Reed, thank you. This is great stuff. And I'm sure we'll be getting updates along the way. And please let Dr. Green know how much I appreciate it, because I did contact you all in the 11th hour because I've been out for a while. But again, there are some people who were not on this. I don't know what happened with sending out our notice, or maybe, it just never got to a number of people, but we'll correct that for the next meeting on June 10th. Now let's move to, this is going to be pretty brief. The agenda item 5, I wrote 2027 legislative proposal. We've been beaten you know, beaten this for several years. Everybody has gotten through their attachments a copy of the legislation that was filed in the Senate in 2026, went nowhere in the House. I'm going to make a comment, and I'll obviously allow anybody to comment on my comments. And I am and have been really flummoxed by the reaction to this legislation over the course of the last couple of years. And I'll go backwards and start by saying, I get the first year that this was introduced, there was not a lot of time for people to discuss, for alternative language to be discussed, for things to be explained, perhaps. And going from the beginning, what this does, this 419 rewrite, right now we have a statute in place, section 419.001. It is a zoning statute. It is a template for the state. Because it was developed 30, 40 years ago, this legislation, this statute that's on the books, it doesn't even include recovery residences because substance use disorder was not seen as a disability. And that's, you know, with all respect, because they're doing their job and doing what they need to do. The Department of Children and Families got this years and years ago, behavioral health, along with churches and mosques and synagogues, you know, because there was no ACA Department of Health view of what is a brain disorder, which is substance use disorder. And mental health was also seen as more of a failing than a health problem. And you know, we can't unbreak that egg, okay? But we have a statute right now that jurisdictions are using as a template that has 1,000-foot separation requirement that municipalities and counties around the state are using right now. And they're waking up because now they have to respond to requests for reasonable accommodation. And by the way, the only way you can get a recovery residence into existence in a municipality or county that has a definition of family and has a prohibition against a certain amount of unrelated adults living together is by by reasonable accommodation. So you got to go through the zoning committees. You got to go through the torches and pitchforks because there's going to be public hearings about it. And that's for everybody. So right now, my understanding is there are several, if not a half a dozen to maybe double digits of existing recovery residences that are having a hard time because now they're located within the 1,000-foot that the municipalities or the counties that are using 419 as it stands right now. Oh, by the way, there's also a 500-foot prohibition to a single family residential district. So for the life of me, I am trying to figure out, other than there's a fundamental disagreement as to federal law and constitution, that any separation requirement, even if there's a reasonable accommodation, if it goes below 660 feet, which is what this has instead of 1,000, that any distance requirement is something that's a non-starter and is something that's dead on arrival. You know, God bless, it's the same thing for me as abstinence only when Matt is the bellwether for recovery, especially for opioids. You know, and I'm not saying this, I'm saying this because I don't understand. I don't understand how we're not better off by having a system in place with a lesser distance and a reasonable accommodation that's on steroids. I'm sorry to mention drugs, but a reasonable accommodation that is expanded to be more tightly written so that municipalities and counties can't, can't phone it in and just make up stuff because they have to jump through hoops. If they're going to say that somebody operating within 660 feet, is not appropriate, or they're not going to give a reasonable accommodation under 419, as we're trying to get it into law, there are very significant roadblocks to that. There can be more. Let's work together. My hair catching fire is last year, not 2 years ago. Last year, when I asked time and time again, bring me alternative language. If there needs to be an economic carve out for intensive outpatient programs, or maybe some kind of a mixed use where it is commercial, residential. Perfect example, you got a Wawa next to a hotel, next to a single family house in Singer Island. To me, that's a mixed use commercial residential where maybe we can tweak this legislation so that you can have non-contiguous, again, recovery community, but non-contiguous. And I know that's the beef about the current recovery community language. So I want to hear somebody giving constructive language that we can discuss in future meetings. It is now April. This legislation, I hope to have both the House and the Senate not only into drafting, but out of drafting by August, so that we're not at the last minute hearing from staff in the House saying we don't understand this, as opposed to the Senate that filed the I see this, and I'm really pouring out my heart. I see this as a step forward. Do I see this as the end result in terms of what can happen if we see that there are problems with the 419 rewrite? Sure. But I see this as a major step forward. One, 660 feet instead of 1,000, which is written into statute right now. There's no 500 feet limitation within a single family residential. And there is permissible use. You have a right outside of 660 feet. If you're FAR certified or an Oxford house, you have a right to locate without the planning and zoning committee or community input. You have a right within this plan. It's worked very well in a number of communities. Writing stronger language, and I'm going to end here. Writing stronger language for reasonable accommodation, again, puts us in a better position than we are now. Yeah. Okay. I'm out of breath. I know there's going to be, I know, Jeff, you are about as long-winded as I am, and I love you, buddy. And I respect you too. And you know that. So I want to hear from you because I really do. I want to understand, but I don't want there to be a long discussion now amongst 5 or 6 people, because we're going to revisit. We have months. We have a half a year, almost, not quite, to get this right. So Jeff, you're on.
Okay, thank you. I'll keep this short, actually, because you just stole my thunder. 6 years ago, with the onset of COVID, this task force continued in its mission, and we did what everyone else did, is we jumped to Zoom, right? I long for the days, and I'm speaking just as Jeff, and not before anyone, because I love the early days of drafting legislation together, and the early days of bringing FAR on board, and all the great work we did sitting around that room at the West Palm Beach Police Department. It was a nice way to see everybody physically, and I think we got a lot done because of that communication style. I love the efficiency of Zoom, but when you are talking about some very significant conversations that have industry-changing impacts and have fair housing and ADA rights sprinkled in there too, and known discrimination, or I'll even say understandable stigma attached to the unknown of people in recovery, by governments and all that. These conversations need to be in a room with the stakeholders that care, to be there and have those conversations. So, I listened to everything you said, Al, because in my role in working with the industry and housing providers and with FAR and NAR and everything, I don't disagree with the thing that you said. Okay, but the decision makers, or the people that are going to actually make things happen to get this across the finish line in some form, need to be at the table and having these conversations. And a Zoom meeting is not the place for that. I mean, they're not here today, but a Zoom meeting is not the effective way to do that. It's not an effective way to get into the nitty gritty of wordsmithing. And you understandably and lovingly send this out to review, and then you get written comments back. That's just not going to work here, in my opinion, because it hasn't worked for 3 years. It's my opinion. And I'm not speaking for anyone. I'm making very clear. I'm sorry, I have a cold. So if we could have this conversation in like a subcommittee format, where the stakeholders that really are going to contribute or want to contribute or care to contribute can get all together and be heard and come up no differently than, I hate to use this word because I can't think of anything else, like a mediation settlement, where you have a facilitated not facilitated, in-person conversation, and people are writing and taking notes and everyone agrees instead of back and forth. And then you bring it back to the full task force and go, hey, look, we met with these people. It's like sending something off to a planning and zoning board before it goes to the city commission, right? I think we need to create that planning and zoning board, or whatever we want to call it, of the overall community stakeholders, the industry stakeholders, the housing stakeholders that really don't understand what any of this means, because it's very complicated stuff. Terrell Pybert and I are speaking tomorrow at the Florida Bar, at the city, county, local government section retreat thing they're having. And tomorrow's all about zoning. And Terrell and I are speaking on this very topic tomorrow, for a bunch of city attorneys about this, and to try to educate them. And I think that's the biggest problem we're having, is not everyone understands all these issues. And so they don't really know how to contribute. And so again, and I'm going to wrap up by saying, Jeff, personally, I think that this form of this legislation, with the input that I was asked to give, has come tremendously far, or no pun intended. It really has. I think for some, the sticky widget remains. And I'm not speaking for anyone again. I'll be very clear that I just, from my, clients or whatever, that their sticky widget is that the spacing remains arbitrary. Not that it's good, not that it's bad, but we're complaining about 1,000 foot, which is horrible, and arbitrary spacing distances, which are unlawful. So we're just replacing one for the other, is their concern, because if the idea is integration or inclusion by separation, and the point is, for everyone who's listening, is you create spacing distances between these uses. Why? Not because they shouldn't be near each other and create a ghetto or whatever it is, or they may create a social service district, is the concern. If you have too many of these uses together, recovery communities in particular, apartment buildings, small apartment buildings in particular, that you're going to basically create what has been labeled as a de facto social service district. And according to the study, that's a bad thing. We don't want that. Okay, I'll acknowledge it. We don't want that. I guess we don't want that. I don't know what that means. It's not a defined term. We don't know what it means, but we're led to assume it's bad. We don't want that. Okay, so we don't want that. So clustering of these uses creates that's bad. So we don't want that. So let's make sure we put spaces in so that doesn't happen. Okay, well, that seems kind of discriminatory. Well, no, we're actually helping the people in recovery by letting them normalize and letting them integrate into the community. I'm like, well, that sounds good too. I get that. We don't want to, but what if they do want to live together? Has anyone studied that? What if they do want to live in a recovery community that people like John Hewlett put their reputation and money behind, and also someone drafted the graphic? What if that's what they want? What if it's good for them? We don't know, and I'm not saying it is, but we skip over that under the premise of half a loaf and no more half a loaf on this issue. enough. Dainu, enough. Is on this issue. Let's figure it out and get it right. We are the diamond of the United States for drug and alcohol treatment. We should be. We can't scare it out of here anymore. We can't do that. We can't chase it out with zoning. We can't do that. There's lawsuits and there's history here. So let's make it awesome. Let's study it. I'm surprised at FAU. I've been begging them for years to put some money behind and figure it, and I thought they did or are going to. Let's figure it out so then we can craft zoning and maybe get some federal money for some incentives. So someone will buy land no differently than affordable housing, or we can get some Live Local Act that includes people in recovery. There's a lot of options out there if you create incentives for it to happen. And I think there's willpower for it to happen. But we need our zoning social scientists to not rely on 50-year-old stuff that has nothing to do with a certified recovery residents. I'm not talking uncertified. We're talking certified recovery residents. As far as been in the state long enough, they're awesome. They're a great organization. Angie's great. Josh is great. The board is great. And you know it. We stand behind them. It's like if you're FAR certified, you should get a nod of the cap as opposed to that's the bare minimum. And you said you had the doctor saying, well, we may give money to non-FAR certified. I mean, that wasn't a politically popular statement. Or realistically popular, but they recognize that there are people out there that may do some kind of group living that we just can't wrap our hands around legally. So what I'm saying is, I think that for this topic for 419, let's get people at the table. I think where there's a will, there's a way. I'm definitely in the mediator mindset, if you know what I mean. Not on this topic, but generally, I think this is what's drafted here. Al is great. I don't love it, but I think it's the best product I've seen to date. And I do want to recognize Dan Lauber for taking in, some constructive commentary on words matter and, the least necessary to achieve the means. I wouldn't, for the lawyers in the group, I wouldn't hide behind Sailboat Bend or Ohio House versus Costa Mesa. Wouldn't hide there. That those cases didn't address this issue. And the issue is what really is good for the recovery community. There's amazing people here. Dr. Phillips, every time she's on, I get inspired. Every time someone speaks, I wish I heard from Nikki Soto more from when she was at NATAP, I'd get inspired. But I'm going to leave it at that, Al. I think that you need to reach out to the people that you know that have an in-person meeting for the people who ever wants to come from this group at the West Palm Beach Police Department. It was a great room. I haven't seen Marianne in years. Let's get together. Let's have meetings in person and flesh this out. It might just take one. It might take more, but let's do that. And I love everybody. So thank you for letting me rant.
Jeff, I love you, buddy, and I do appreciate your brevity. Listen, I like you. I do miss the in-person meetings. However, if you look at the makeup of this group, there are a number of people who do not live locally. And I'm not, and Dan is not a part of the task force. But there are a number of others that we were lucky to have FAR locally. I mean, originally when this task force was begun, we were mandated to have DCF. We were mandated to have a Florida Certification Board. Neil lives in Broward County, and a lot of times he's in Tallahassee. FADO, which is now the Behavioral Health Network, they were mandated to be on this task force. And yes, Mark Fontaine did fly into Miami and drive to the meetings, but that was when everything was going to hell in a handbasket. And it's not practical, but maybe we can have, and I like the work group. Maybe we can have a hybrid Zoom in person, and maybe at the healthcare district, because they do have the facility. I don't know that they have that in West Palm in their meeting room, but we can probably find a place where we can have a 6 or 7 person, hands-on, talk about the language, debate it, but here's the thing. Number one, it wasn't a matter of having Zoom. I didn't get any recommended changes in the language. None last year. And I know Dan's got his hand up, and number two, nobody's hiding behind. I do take issue with saying so anybody's hiding behind case law that's 30 years old or 20 years old or even more recent. The studies were done. This is a bad analogy, but vaccines for polio, there aren't any more studies. We're not going to get any more studies about that. And one of the things about the studies were, be careful what you wish for, because property value studies were based on lone houses. They were not based on communities that have 50-50 or 40-60. I get what you're saying about if people choose this, but when you're talking about even multifamily communities that are actually multifamily residential, no study has been done as to whether the idea that was hatched 2 years ago in legislation to have an unlimited number of duplexes, triplexes, and quadplexes in a multifamily district was going to affect property values for the people who are not. I don't know. But I don't know that there'll be any studies. So this is something we're going to, if we can engage in the conversation, and I'd love to hear that you're saying, hey, you don't want a half a loaf, but you at least see this as an advancement over what was or what is actually in legislation. We have something to work with. If it's going to be coming in and saying any spacing distance is dead on arrival, then I don't think meeting in a small group is going to matter. It's just going to be dead, and we're going to continue on with 1,000 foot. Again, I'm sorry. I made this much more now. We can have these discussions in a subcommittee. I'm going to start a subcommittee where it's going to be a hybrid. We'll figure it out. We'll figure out in person. Terrell, you, me, and Dan can be on Zoom because there's nobody going to pay his freight to come back and forth for these, but we'll figure it out. If there's anything that can be figured out, but if it's kind of like the mat dead enders, and that's another bad analogy, but I don't like it because you're invading my right to have my business do what my business wants to do and forget about what all the studies that are there say. I don't know how you can negotiate out of that. We tried last year with the mat thing and it didn't work. I mean, we tried every which way with reasonable accommodation. But Dan, you go ahead. You got the last chat here, and then we will continue this, I promise you, because we have a good 4 months of being able to debate this out and come up with alternative language that may make it palatable to do.
Okay, thank you. Appreciate what Jeffrey said. And I just encourage people here who have not read the state study, please read it. It addresses just about everything Jeffrey raised and explains the rationale for all of the recommendations. And just to give you a quick idea, the 660 feet is a typical block in America. There's over 50 studies on the impacts of community residences, including recovery residences, on property values, property turnover rates, and neighborhood safety. The overall overwhelming conclusion is as long as they are not clustered on a block, in other words, don't have 2 or 3 or 4 on a block, and they are licensed or certified, they have no impact on property values, turnover rates, or neighborhood safety. As Al mentioned, no one's doing these studies anymore because it's so well settled, and that's addressed in Appendix A of the study. So I encourage you, as I told the doctor, don't try to read it all at once, but if you read it in a chapter a day, say, take some notes, you will get a very clear picture of how what we've been proposing for 419's complete overhaul of provisions, which, as one chapter in the study shows, are illegal under the Fair Housing Act. How what's proposed is the least drastic means to achieve legitimate government interest, which is the bottom line test under the Fair Housing Act for zoning regulation. And the experience that the cities in Florida that have adopted this, as well as the ones I've worked with in Arizona that have adopted this approach, has been that the overwhelming number of community residences, including recovery residences and recovery communities, are allowed as permitted uses. There's no hearing involved, no big expense for an attorney. The very small number that have to go through a hearing, what we've proposed in 419 establishes really strong, pretty darn objective standards that would result in the overwhelming majority of, in the case of recovery residences, being approved, and takes out the subjective nature. I'm dealing with one community right now, Al, that's using the state statute as its basis, and they're a mess, and their ordinance is illegal as hell, but you can't tell them that because they're not going to grant their reasonable accommodation for the operator that I'm helping. So again, please read the study, grouphomes.law. Ignore any warning from your browser that the site's insecure. I mean, it has security issues. It's, feels nobody loves it, but that was a bad joke. Sorry. That's the Groucho Marx in me. Say this equal wage to win $100. But thank you all for participating in this. I really am impressed by the work everyone's doing. And I think that if we can get 419 in its current form or a more advanced form adopted, it will really open up the entire state, because as Al has pointed out at previous meetings, there are parts of the state of Florida where it's practically impossible to get a recovery residence in. And they're requiring all of them to go through a special use permit. And that's just not legal. That will eliminate that and really make it a lot easier for operators to establish their homes in those parts of the state where there is a severe shortage. Anyway, thanks very much for the opportunity to address the group.
Well, I'm going to figure out how to do a subcommittee. I am going to talk to the folks over at Healthcare District, because they do have facility for us to do that as a hybrid with Zoom and with live. I'll talk to people online, and that meeting, I don't see this is a think tank. It's not I'm not a chair of a committee or a subcommittee of the state attorney. Heck, a lot of people don't even believe that this is our core function, but public safety is always the state attorney's office core function. And I think a lot of this and a lot of what we've done in 10 years has been public safety in terms of saving lives of people who have substance use disorder, as well as community public safety. So we'll figure out how the public can be invited to the meeting. I'm thinking Healthcare District. I don't know that they're still on, so I'm volunteering their space, but we'll see what happens. And I am cautiously optimistic that we can do something that no other state has done in terms of making it easier for good, safe, not only substance use disorder housing, not only recovery housing, but again, everything is under the same umbrella for people with disabilities. So it's all ADA, FHAA. That's why it's everybody. We're not just talking about other than recovery communities, which is a subset and in and of itself. So anyhow, anything for the good and welfare, both from the Saartf or from the public. Anybody want to make a comment before we adjourn? I thought this was going to be an hour-and-a-half meeting, and here we are almost going up to the line. So anybody have a comment?
You have a hand up.
I have a hand up. Oh, I see it. Oh, Michael, go ahead.
Yeah, just a question for Dan. He said that there's some areas of the state that currently are not able to open any recovery residences. I was just wondering if you could say which areas of the state those are.
Well, I didn't say you can't open any. I said you can't open them as of right. You're going to have to go through a special use permit
Okay,
process.
I got
That's
you.
most
That's the
places.
frustrating thing. And I wanted to emphasize, I forgot to say this, I'm perfectly happy to do virtual education sessions for any municipality, any group of attorneys. I got to tell you, when I work with these cities, we do one-on-one meetings with each city commissioner. I've got a fairly lively, entertaining PowerPoint I do, answer questions. They come out of these meetings, including those that were against making any changes, supporting it because we're able to make it clear how it works. Also on the grouphomes.com.law website is a webinar I did for the Michigan Department of Civil Rights on this, that if you want to get a clearer picture of what this is all about and the underlying rationale, it'll take you 40 minutes. You'll get it. It'll be helpful. And it does incorporate the Princess Bride into it. Very important to do that. I always have found out. So at that, again, I'm open to do this for any attorney group, municipal attorneys, any city, any group of operators to educate them how to get through the zoning process. This is something I've done, I can't count the number of times. And it turns out to be very useful. And the great thing is, with educating the operators, they don't need a lawyer to get through the zoning process. They know how to do it really well afterwards.
By the way, we're going to send out a link to the study to everybody who's on our mailing list, not just everybody who's a member of the task force, but everybody who's on our mailing list. That's number one. Number two, if I read between the lines of what Michael was asking you, and I think this is very important because traditionally Oxford House has been the only knight in shining armor that can take to task a local government entity that is shutting the door because they have the resources that providers don't have. That if you see, for example, the patently illegal behavior of that particular municipality in the case that you tried to intervene on, I think that Michael, correct me if you don't want to hear this, but would you like to get that information? If there's a municipality that they're just going through the motions, but they're patently violating federal law with looking at the 419 as it exists now and
Yeah, absolutely.
not having a reasonable accommodation that makes a difference at all.
Yeah, I mean, so much is so I'd go open a house there just to see what happens.
Okay.
Yeah.
So Dan, we'll send you or we'll figure out, get you guys each contact info for each other.
Sure.
And Terrell, I notice you're here. I know you signed on a little late. Is there anything you want to add to the daunting task of working 419 so it has the best chance of passing next session, or just anything for the good and welfare on the issue?
Thank you, Alan. Welcome back. Glad to see you on here and glad to be on here with everybody. I have been kind of quiet, as Jeffrey Lynn mentioned. We are talking tomorrow to the land use law section of the Florida Bar, which is kind of an add-on to the city, county, local government section of the Florida Bar, and we're going to be presenting on community residences. And I mention that because I think it's relevant to your question, in that I do think that more education of cities and counties is helpful. In addition to the legislation, I'm hopeful that by virtue of speaking tomorrow, that will help to at least get this in everybody's minds, because there will be representatives there from cities, counties, and other land use lawyers from around the state. And I do plan to mention, and I know Jeffrey does as well, the Chapter 419 rewrite, and kind of direct them to the study and the recent legislation that unfortunately didn't get any traction this year, but hopefully will next year. Beyond that, beyond education, I do think that needing to really try to fine tune it and come up with something that everybody can live with, is in everybody's best interest, because this is an important task, and this board is doing great things. And as you said earlier, I'm very inspired by everything that Dr. Phillips and Dr. Andrick and Dr. Reed are doing. And I think that if we can help to make community residences permitted use as much as possible, and kind of take out some of the subjectiveness in reviewing reasonable accommodation requests, I think that we'll all be better off, and we'll be able to provide more opportunities for housing for people who need it. But that's really it. I don't have any.
Okay, I'll tap some folks. Everybody will know if we have a subcommittee meeting, because it's going to be an open meeting. I began to say, I don't believe that this is a sunshine committee as such, because really, these are a lot of voices that are, on public safety, but I've always treated it in terms of, that's why we have people sitting in that are not part of the task force. There's more people are public than are connected to the task force. So any subcommittee that we have in person will be public. Probably you're going to have to show up, to be in it. But I don't know. We'll see what the Zoom capacities are. With that, thank you so much. This is great stuff. Thank you, Dr. Reed. Appreciate it. Thank you. I don't know if Dr. Phillips and Dr. Andrick are still on, because they had a bunch of stuff to do. They left, but it was, this is awesome stuff. And I know Ann Berner, somehow or other, a bunch of people did not get the Zoom coordinates. It may be because I was out for several months, and everybody, stopped thinking about having this bi-monthly, or it was all our IT department's fault, in which case they're all fired. But Ann, I see you're on now. It was a great meeting. I had called you earlier and I do, for the next meeting, want to hear about innovations and what's happening in this fiscal year and going forward. So bet on it. I'll be calling you up, and we'll have you for the next meeting presenting.
You got it, Al. No problem. Thank you.
I appreciate that. And this is all good stuff, because you were mentioned, you meaning SEPN was mentioned, in terms of how well everybody's coordinating with each other. And we're getting better results because of it, both in terms of the housing vouchers and in terms of treatment between SEPN and your contracts and the healthcare district. I just can't be happier with how things are trending. And you missed the numbers at the beginning, but we haven't seen numbers like this since the pill mill days, as far as Palm Beach County with overdose deaths, drug overdose deaths, opioids specifically, but even above all, just all drugs. And so we're heading in the right direction. And you all have a great rest of the month in May. We'll see you June 10th.